Today's class is on drugs for gout and anti-rheumatic drugs. What do we mean by gout? Anyone? একজন জোরে বলো। Yes, deposition of the uric acid in the joint leading to the inflammation of the joint, pain, red swelling. What do we mean by rheumatoid arthritis? Sorry, huh? It's an autoimmune disorder leading to the destruction of the joint. Now, rheumatoid arthritis is an autoimmune disease causing joint inflammation, proliferation of synovial cells, and destruction of the articular cartilage. It's a chronic progressive crippling disease. কখনো বাড়ে কখনো কমে যায়, having waxing and waning course. Now, what is the basic pathology here? The immune complexes consisting of IgM, they activate complement and the release of cytokines. Mainly two cytokines, they play a major role. One is TNF alpha and the other one is IL-1, interleukin 1. What does they cause? They cause release of chemotactic factors causing neutrophil chemotaxis. These inflammatory cells, they release lysosomal enzymes which causes destruction of the cartilage and bony erosions. While the prostaglandins release, they cause vasodilatation and cause pain. Now, what's the goal of drug therapy in rheumatoid arthritis? প্রথমটা symptomatic relief. একটা পেশেন্ট জয়েন্ট পেন সোয়েলিং নিয়ে এসে তাকে ব্যথা কমাতে হবে, so to ameliorate the pain, swelling and joint stiffness. The second goal is the prevention of the destruction of the joint, which is the basic pathophysiology in the rheumatoid arthritis. Prevent articular damage, articular cartilage damage, and prevent bony erosion. And finally, and most importantly, prevent deformity and prevent joint and preserve the joint function. Anti-rheumatoid drugs. These are drugs which basically suppress the rheumatoid process. Rheumatoid process means ki we suppress the destruction of the cartilage and we suppress the bony erosion. So these are drugs except corticosteroids which suppress the rheumatoid process, bring about a remission and retard disease progression, but they do not possess any analgesic property, they do not possess any anti-inflammatory property as such. These drugs are also called DMARD, that is disease modifying anti-rheumatic drugs, or SAARD, that is slow acting anti-rheumatic drugs. The onset of benefit, it takes few months. It's not that ওষুধটা নিলাম সঙ্গে সঙ্গে কাজটা করলো, তা নয়। ওষুধটা আরম্ভ করার পর কিছু মাস লাগবে টাইম কাজ করতে। So onset of benefit takes few months of regular treatment and relapses occurs after cessation of therapy for few months. Recently, some biological agents, কিছুটা এমনি synthetic DMARD আছে, তার উপরে এখন recently some biological agents have been added, like TNF alpha inhibitors, like interleukin 1 inhibitors. So recently some biological agents have been added for the treatment of resistant cases of rheumatoid arthritis. Now, these are classification of drugs used in rheumatoid arthritis. Number one is disease modifying anti-rheumatic drugs, also called DMARD. They include non-biological drugs and they include biological drugs. Non-biological drugs include immunosuppressants, particularly very important, methotrexate is the drug of choice in rheumatoid arthritis. Also include azathioprine and cyclosporine. Other immunosuppressants which include sulfasalazine, commonly used, chloroquine or hydroxychloroquine, commonly used in malaria treatment, but they are also used for the treatment of rheumatoid arthritis, and leflunomide and tofacitinib. Now, biological agents include TNF alpha inhibitors, particularly infliximab, etanercept, adalimumab. These are TNF alpha inhibitors. Other biologicals include anakinra, is the IL-1 receptor antagonist, abatacept, and rituximab. Adjuvant drugs include corticosteroids, that is prednisolone and others. Now coming to non-biological drugs, like methotrexate is the drug of choice in the treatment of rheumatoid arthritis. Mechanism of action, it inhibits dihydrofolate reductase enzyme. It's a prominent immunosuppressant and have anti-inflammatory property. Now, methotrexate is primarily used in anti-cancer treatment in very high dose, but in very low dose, it is used for the treatment of rheumatoid arthritis as DMARD, disease-modifying anti-rheumatoid drug. What the mechanism? It inhibits cytokine production, inhibits chemotaxis and cell-mediated immune response. Proliferation of immune inflammatory cells are inhibited. Now, oral bioavailability variable, food may affect the absorption, excretion hindered in renal disease. So, better to avoid drugs in renal failure patient. So, not recommended for such patient. Now, induction of oral low dose weekly regimen, around 7.5 to 15 milligram weekly we give it. Methotrexate regimen has improved acceptability. Now, preferred for the initial treatment. Now the DMARD of choice. Why? Because the onset of action is quite fast compared to other drugs. It's around 3 to 6 weeks. Response more predictable and sustained over long term. Now, even if we use 2 or more DMARD, methotrexate generally is one of them. Now, drug interaction, probenecid and aspirin, they increase the methotrexate level. Trimethoprim again inhibit DHFR, dihydrofolate reductase enzyme. So, more inhibition of folic acid synthesis. Side effect, commonly oral ulceration and gastrointestinal upset. Dose dependent progression of liver disease, in fact to the cirrhosis of liver, can occur with prolonged therapy. Incidence of chest infections are increased. Contraindication, pregnancy, lactation, liver disease, active infection, leukopenia and peptic ulcer disease. Azathioprine is the purine synthesis inhibitor. It's a prodrug that is converted to 6-mercaptopurine by the enzyme thiopurine methyltransferase. It is a potent suppressant of the cell-mediated immunity. এগুলো তুমি anti-cancer therapy আরো details পেতে পড়বে. Appears to selectively affect differentiation and function of T cells and natural killer cells. They also suppress inflammation. The main thing is that azathioprine is not combined with methotrexate. যখন আমরা 2 or more than 2 DMARD use করব in the treatment of rheumatoid arthritis, then we should not combine methotrexate with azathioprine because they will be added bone marrow suppression. Given along with corticosteroid, it has a steroid sparing effect. যে পেশেন্টটা একটা long term high dose steroid লাগছে in the treatment of rheumatoid arthritis, if we give azathioprine, then we can easily decrease the dose of corticosteroid. Sulfasalazine. Sulfasalazine basically is a combination of 2 compounds. One is sulfapyridine and the another one is 5-amino-salicylic acid. The drug is used in inflammatory bowel disease because of the active moiety 5-amino-salicylic acid. Is basically the compound 5-amino-salicylic acid, that is ASA, that is not absorbed, that acts locally in the colon in the patient of inflammatory bowel disease. Now, in this patient of rheumatoid arthritis, the another compound sulfapyridine, that is absorbed systemically and possibly that is the compound that is helpful in the treatment of rheumatoid arthritis, right? So, it's a compound of sulfapyridine and 5-asa-amino-salicylic acid. Sulfapyridine is split off in the colon and absorbed systemically, appears to be the active moiety. Generation of superoxide radicals and the cytokine elaboration are suppressed. Efficacy modest, not as better than methotrexate. And side effects are unpleasant. Neutropenia, thrombocytopenia may occur. So a patient on sulfasalazine, regular blood count is necessary. Hepatitis may be possible. It is used as a second line drug where the methotrexate is either intolerant or is not effective. It is used as a second line drug for milder cases or may be combined with methotrexate when the combination drug is needed. Hydroxychloroquine or chloroquine. These are basically anti-malarial drugs. They induce remission in rheumatoid arthritis patient up to 50%, not more than that. So its efficacy is a bit low compared to sulfasalazine and compared to methotrexate. But it takes 3 to 6 months of time to initiate the action. Relatively low toxicity compared to other drugs, but the efficacy is also low and it does not prevent bone erosion. Mechanism of action not known, possibly it reduces monocyte interleukin 1 and thus inhibiting B lymphocytes. Now drug has to be taken for long period. Now what happens? They accumulate in tissues, especially melanin containing tissues, and the most prominent action is on the retina, causing retinal damage, on the cornea, causing corneal deposits. Now this retinal damage and corneal opacity are reversible and basically less common with hydroxychloroquine compared to chloroquine. That is why hydroxychloroquine is preferred over chloroquine in a patient of rheumatoid arthritis. Other side effects are rashes, graying of hair, irritable bowel syndrome, myopathy and neuropathy. Employed in generally milder non-erosive cases, কেন কি bony erosion prevent করে না, especially when only one or a few joints are involved, or they are combined with methotrexate with sulfasalazine. Leflunomide. Leflunomide basically inhibit dihydroorotate dehydrogenase and thus inhibit pyrimidine synthesis. Antibody production by the B cells are suppressed. Now efficacy is as better compared to methotrexate. দুটো efficacy more or less একই আছে and action is fast. The onset of benefit is fast, around 4 weeks, like that of methotrexate. So active metabolite has a long half-life of 2 to 3 weeks. So in a patient who is intolerant to methotrexate or where methotrexate is contraindicated, leflunomide can replace methotrexate. মানে methotrexate জায়গায় কিন্তু leflunomide use করতে পারি আমরা because it is as efficacious as methotrexate and the onset of benefit is also fast like methotrexate. Adverse effects: diarrhea, headache, nausea, rashes, loss of hair, thrombocytopenia, leukopenia, raised transaminase level. These are the common side effects, not to be used in children and pregnancy and lactation. It is an alternative to methotrexate or can be added to it, but the combination of methotrexate and leflunomide should be avoided to prevent hepatotoxicity. Combination with sulfasalazine improves benefit. Generally methotrexate যেখানে ইউজ করতে পারছি না সেখানে কিন্তু আমরা leflunomide ইউজ করি. Now coming to biological agents. Biological agents, these are expensive, having prominent adverse effects. So they are reserved for severe refractory disease. Now among them, one is TNF alpha inhibitor that is most commonly used. TNF alpha inhibitors, basically TNF alpha play a key role in the inflammatory cascade of rheumatoid arthritis patients. It acts on the TNF receptor 1 and TNF receptor 2 and subsequent inflammatory cascade occurs. The TNF alpha inhibitors, they mainly suppress macrophage and T cell function. They are quicker in response than the non-biological agents. Methotrexate থেকেও তাড়াতাড়ি কাজ করে. Effective as monotherapy, but they are never used as monotherapy. They are generally combined with methotrexate. When response to methotrexate not adequate or in rapidly progressive cases. The problem with these drugs are susceptibility to opportunistic infection. particularly tuberculosis and pneumocystis pneumonia. That is why they are rarely used. Only in severe cases where methotrexate alone or in combination are not effective. Infliximab is a chimeral monoclonal antibody administered intravenously. Etanercept, here the TNF receptor is fused with the IgG1 FC portion administered subcutaneously. Adalimumab is a human monoclonal recombinant anti-TNF antibody. Corticosteroids. Corticosteroid is a potent immunosuppressant and anti-inflammatory drug. Now, it can be used at any stage of rheumatoid arthritis, irrespective with the NSAID with the DMARD. Now, symptomatic relief prompt and marked, but they do not arrest the rheumatoid process. Rheumatoid bone erosion, destruction take prevent korte pare na, but they may delay the progression. Long-term use carries serious disadvantage. So either low doses are used for long periods so that the disadvantages are less, or high dose are used for the short periods. Now, in cases of single or few joint involvement with severe symptom, even intra-articular injection of soluble glucocorticoid is used. Now, these are the Euler recommendations, from the Europe for the treatment of rheumatoid arthritis, last updated on 2022. They said therapy with DMARD should be started as soon as the diagnosis of rheumatoid arthritis is made. Treatment aimed at reaching a target of sustained remission or low disease activity. Monitor in cases of active disease, monitoring should be frequent as every 1 to 3 months. Methotrexate should be the part of first treatment strategy. Methotrexate. In case of methotrexate contraindication or intolerance, leflunomide or sulfasalazine should be considered. Leflunomide is more effective. Short-term glucocorticoid should be considered when initiating or changing CSDMARD. In these recommendations, they have divided DMARD into three groups. One is CSDMARD, that is conventional synthetic, like methotrexate, like leflunomide and sulfasalazine, hydroxychloroquine. And then other one is BDMARD, that is biological DMARD. And the last one is T for target specific DMARD, TS. That include basically newer generation anti-rheumatoid drugs like Janus kinase inhibitors, tofacitinib, amra namta dekhechhilam. So short-term glucocorticoid should be considered when initiating or changing CS or conventional synthetic DMARD, tapered and discontinued as rapidly as possible so that the side effects are less. If the treatment target is not achieved with the first CS-DMARD, in the absence of poor prognostic factor, other CS-DMARD may be added, like sulfasalazine. Biological DMARD or target specific DMARD should be combined with CS-DMARD in patients who cannot use the other CS-DMARD as co-medication. যেখানে অন্য DMARD sulfasalazine use করতে পারছি না, সেখানে কিন্তু we can use biological DMARD. If a biological DMARD or target specific DMARD has failed, then treatment with another biological DMARD or TS DMARD should be considered. After glucocorticoid has been discontinued and patient is in sustained remission, dose reduction of DMARD should be considered. These are some of the recommendations made by the European Association of Alliance for Rheumatoid Arthritis. Gout. Now, gout is a metabolic disorder where the uric acid level in the blood increases. What's the problem? Uric acid is a low water soluble drug, basically low water soluble compound. Now, it precipitates in the low pH. Now, when the uric acid comes in the synovial fluid, because of the low pH, it precipitates there. Uric acid crystals causes inflammation in the joint. So gout is a metabolic disorder characterized by hyperuricemia. Uric acid is a product of purine metabolism having low water solubility, especially at low pH. Excess uric acid hence precipitates and get deposited in joints, in the kidney causing renal stone, and in the subcutaneous tissue causing tophi. Tophi is basically uric acid crystals under the skin. They are commonly found in the pinna, in the nose, in the eyelid, and other places, in the near the joint and other places. Now, secondary hyperuricemia. একটা hyperuricemia primary যেখানে metabolic disorder এর জন্য uric acid level বেড়ে গেছে. Now, secondary hyperuricemia is due to some other causes for which the uric acid level has raised, particularly in case of leukemia, lymphoma, and polycythemia. Here the number of cells in the body increases drastically. So what happens? Uric acid is a product of purine metabolism. Now, due to more and more nucleic acid metabolism, more purine is formed, more uric acid is formed. That is causing increase in the blood uric acid level. So, patient of leukemia, lymphoma, polycythemia, particularly on chemotherapy or radiation therapy, this is causes secondary hyperuricemia due to enhanced nucleic acid metabolism and uric acid production. Secondly, drug induced, like thiazides and furosemide. These are diuretic drugs, like antitubercular drug, pyrazinamide, ethambutol. These are the drugs, levodopa. They reduce uric acid excretion by the kidney and thus cause hyperuricemia. Now, these are the drugs for gout. একটা গাউটের পেশেন্ট ট্রিট করতে গেলে পেশেন্টটা একটা জয়েন্ট ইনফ্লামেশন নিয়ে আসছে, এখানে প্রথম আমরা কিন্তু ড্রাগস দিই ফর অ্যান্টি ইনফ্লামেটরি অ্যাকশন, জয়েন্ট পেন স্বেলিংটা কমানোর জন্য। ইউরিক অ্যাসিড লোয়ারিং ড্রাগটা পরে যোগ করা হয়, সেটা পরে আসছি আমরা। হ্যাঁ, সো ড্রাগস ফর অ্যাকিউট গাউটি আর্থ্রাইটিস অ্যান্ড ফর দ্য ক্রনিক গাউট আর হাইপারইউরিসেমিয়া. For acute gouty arthritis, 3 drugs are there, 3 groups of drugs are there. One is NSAID, that is the non-steroidal anti-inflammatory drug. Next is colchicine, and the third is glucocorticoid. Of them, NSAID is the drug of choice. The second line agent is colchicine. For chronic gout, we use uricosuric drug that increases the uric acid excretion from the body, like probenecid and sulfenpyrazone, and the uric acid synthesis inhibitors like allopurinol and febuxostat. ঠিক আছে রে? Now, acute gouty arthritis. Acute gouty arthritis manifests as sudden onset of severe inflammation in the small joint due to precipitation of uric acid crystals. Now, the most common joint involved in a patient of acute gouty arthritis is the first metatarsophalangeal joint of the great toe, but other joints can be involved. Now, why the attack occurs? Because of the precipitation of uric acid crystals in the synovial fluid. What happens? The synovial cell engulfs the uric acid crystals and release of chemotactic factors occurs, causes granulocyte chemotaxis into the joint, and these granulocyte engulf the uric acid crystals. They release a glycoprotein that causes, number one thing, lactic acid production, and number two, release of lysosomal enzymes. This lactic acid increases the local pH, so more uric acid precipitates in the joint, and lysosomal enzymes causes destruction of the joint. Joint becomes red, swollen, and extremely painful, and requires immediate treatment with strong anti-inflammatory drug without attempting to lower the blood urate level. ঠিক আছে, পেশেন্ট একটা ইনফ্লেমড জয়েন্ট নিয়ে এসছে ডিউ টু অ্যাকিউট গাউটি আর্থ্রাইটিস, we decrease the inflammation first. We do not lower the blood uric acid level. After the inflammation subsides, we add uric acid lowering drug, either uricosuric agent or uric acid synthesis inhibitor, under the cover of an anti-inflammatory drug for a period of 1 to 2 months. This is because in the initial treatment with uric acid lowering drug, there is fluctuation in the level of uric acid. Sometimes the uric acid level goes up, in the initial period, sometimes goes down, and due to this fluctuation in uric acid level, sometimes the uric acid crystal in the joint, they solubilize due to the decrease in uric acid level, or they precipitate again. That causes repetition of the acute gouty arthritis attacks. So we do not use any uric acid lowering drug when a patient comes with acute gouty arthritis. We give an anti-inflammatory drug, preferably NSAID. We decrease the inflammation, then we use any uric acid lowering drug under the cover of an anti-inflammatory drug for a period of 1 to 2 months. When acute attack subsides, urate lowering therapy is instituted and anti-inflammatory cover is given for several weeks. If hyperuricemia is not controlled, attacks recur and involve many joints, resulting in the chronic deforming arthritis. Now, NSAIDs. Now we are coming to the treatment of acute gouty arthritis. Of them, the first is the NSAID. It is one of the strong anti-inflammatory drugs. The preferable drugs are naproxen, pyroxicam, diclofenac, and indomethacin because of their strong anti-inflammatory action. Now, this pyroxicam and naproxen, they have got added advantage. They inhibit the chemotaxis of neutrophils in the joint. Given in relatively high and quickly repeated dose, quite effective in terminating the attack, but they take 12 to 24 hours and the resolution takes 5 to 10 days. Response is slower than colchicine, but definitely NSAID is preferred because they are better tolerated. Colchicine side effects are very high. Majority of patients prefer NSAIDs over colchicine. They are strong. Naproxen and pyroxicam specifically inhibit chemotactic migration of leukocyte into the inflamed joint. After the attack is over, NSAID should be continued at lower doses, already discussed, for 3 to 4 weeks, while drugs to control hyperuricemia take effect. Now, colchicine is an alkaloid obtained from the plant Colchicum autumnale. The drug particularly, it does not have any analgesic or anti-inflammatory property. The drug specifically inhibits inflammation of acute gouty arthritis, not any other inflamed joint. So it is diagnostic of it. একটা পেশেন্ট যদি ইনফ্লেমড জয়েন্ট নিয়ে আসে, কলচিসিন দেওয়ার পর ইনফ্লামেশন কমে যায়, that is diagnostic of acute gouty arthritis. It is so specific for it. So it is neither analgesic nor anti-inflammatory, but it specifically suppresses gouty inflammation. It does not inhibit the synthesis nor promote the excretion of uric acid. Now, it does not affect phagocytosis of urate crystals, but they inhibit release of chemotactic factors and the glycoprotein. They also inhibit granulocyte migration into the inflamed joint. Rapidly absorbed orally, partly metabolized in liver, excreted in bile, undergoes enterohepatic circulation. So basically half-life is longer. Inhibitors of CYP3A4, they retard colchicine metabolism and increase their toxicity. Toxicity is high and dose related. More commonly, gastrointestinal side effects, nausea, vomiting, diarrhea, abdominal cramps. In overdose, kidney damage, CNS depression may occur, intestinal bleeding may occur. Death is due to muscular paralysis and respiratory failure. Fastest acting, but second line option to NSAID because of higher toxicity. Corticosteroids, intra-articular injection of soluble steroid when only one or few joints are severely inflamed and in those not tolerating NSAID or colchicine. Systemic steroids rarely needed. They are highly effective, but reserved for renal failure, history of peptic ulcer disease, and in whom NSAIDs are contraindicated or not responding. Chronic gout or hyperuricemia. What do we mean by chronic gout? দুটো attack of acute gouty arthritis মধ্যে যদি joint pain, stiffness থেকে যায়, the patient is having chronic gouty arthritis. So when pain and stiffness persist in a joint between attacks, gout has become chronic. Now, other cardinal features are hyperuricemia, blood uric acid level টা রেস্ট থাকবে, second renal stone, Third is formation of tophi under the skin. These are some of the cardinal features of chronic gouty arthritis. Eta acute pabe na. In majority of patients, hyperuricemia is due to under excretion of uric acid, but in some they can be overproduced also. Uric acid বেশি তৈরি হচ্ছে বা বেশি বেরিয়ে যাচ্ছে, কম বেরিয়ে যাচ্ছে. These are the two major pathophysiology for hyperuricemia. Majority are under excretors, but some may be overproducers. Now, chronic gouty arthritis may cause progressive disability and permanent deformities. Uricosuric drug কি আছে? Allopurinol, probenecid, sulfenpyrazone. Probenecid is a highly lipid soluble drug. It was initially produced for prolonging the action of penicillin. What does they cause? They basically block the active transport of organic acid by OATP, that is organic acid transport protein, je kono site, biliary tract ba kidney the. Now penicillin is secreted by the renal tubules. Now they block the secretion of penicillin, and thus they prolong the duration of penicillin. Now it was initially produced for this action, but it has been seen that this drug also basically causes increase in the secretion of uric acid, decrease in the reabsorption of uric acid. So hyperuricemia decreases. They competitively block active transport of organic acid by OATP at all sites. This transport is bidirectional. কিছু ড্রাগটা কিছু কম্পাউন্ডটা সিক্রিট হয় OATP থেকে বেশি, কিছু কম্পাউন্ডটা রিঅ্যাবজর্ব হয় এতে বেশি. পেনিসিলিনটা সিক্রিট হয় আর ইউরিক অ্যাসিডটা রিঅ্যাবজর্ব হয়. Net effect of probenecid on excretion depend on whether secretion or reabsorption of particular organic acid is quantitatively more important. For example, net effect of probenecid is inhibition of penicillin excretion, and uric acid is largely reabsorbed by active transport. Major transporter is urate 1. Probenecid inhibits reabsorption and promote excretion of uric acid. Interaction: number 1 is penicillin with penicillin and cephalosporins. What does they cause? Because they increase the duration of action of these drugs along with methotrexate and indomethacin. Now they inhibit the biliary excretion of the rifampicin. Now coming to other antitubercular drug, that is pyrazinamide, causes hyperuricemia, and also the ethambutol, more pyrazinamide. So they may interfere with the uricosuric action of the probenecid. This is a pharmacodynamic interaction. Now inhibits tubular secretion of nitrofurantoin. Nitrofurantoin is an antibacterial agent used for urinary tract infection. Now if it is inhibiting the secretion of nitrofurantoin, what happens? The concentration attained in the urine will be low, and so its antibacterial efficacy will decrease. Pharmacokinetics: completely absorbed orally, 90% plasma protein bound, partly conjugated in liver and excreted by kidney. Adverse effect: generally well tolerated. Dyspepsia is the most common side effect. It should be used cautiously in peptic ulcer patient. Rashes, hypersensitivity reactions are rare. Usage: very important, chronic gout and hyperuricemia. Is the second line drug. The first line drug is allopurinol, the uric acid synthesis inhibitor. Now is the second line drug to allopurinol. Arthritis, tophi and other lesions may take months to resolve, but they should be avoided in nephropathy patients. They are ineffective in renal insufficiency. Patients with renal stones should not be given the drug, and plenty of water should be given with it. Prolongs penicillin or ampicillin action by enhancing their blood levels, and they are also given along with cidofovir. Cidofovir is used in HIV patients with CMV retinitis, cytomegalovirus retinitis. Now this drug probenecid, they prevent the nephrotoxicity of cidofovir. Sulfenpyrazone is another uricosuric drug. Now it's a pyrazolone derivative related to phenylbutazone. Phenylbutazone is an NSAID, but although it is related to phenylbutazone, it has not got any analgesic nor any anti-inflammatory property. It's a uricosuric drug, inhibits tubular reabsorption of the uric acid. But this drug is not used nowadays because of gastric toxicity and other side effects. Lesinurad is again a uricosuric drug, mechanism of action similar to probenecid, and this drug has recently been approved by US FDA for the treatment of hyperuricemia alone or in combination with allopurinol. Uric acid synthesis inhibitor, allopurinol and febuxostat. Coming to allopurinol, it's a hypoxanthine analog. This is hypoxanthine. This is converted to xanthine, converted to uric acid in the body. Now, this action is catalyzed by xanthine oxidase. Now, allopurinol, it basically inhibits xanthine oxidase competitively. Now, again, this enzyme, xanthine oxidase, it acts on allopurinol to convert it into alloxanthine. So, basically, allopurinol is an inhibitor of xanthine oxidase. It's a substrate of xanthine oxidase. Now, this alloxanthine again is a non-competitive inhibitor of xanthine oxidase. বুঝা গেছে? So it's a hypoxanthine analog synthesized as purine anti-metabolite. এটা তৈরি করা হয়েছিল because of anti-cancer property ভেবে, কিন্তু it has got no anti-neoplastic activity. It basically acts as a substrate and inhibitor of xanthine oxidase responsible for uric acid synthesis. So allopurinol is short-acting, half-life 2 hours. It's a competitive inhibitor of xanthine oxidase enzyme. But its major metabolite alloxanthine, যে বললাম, because of action of xanthine oxidase, allopurinol is converted to alloxanthine. It has a long half-life, 24 hours, and it's a non-competitive inhibitor of xanthine oxidase. Now, during allopurinol administration, plasma concentration of uric acid is reduced, while hypoxanthine and xanthine somewhat increased. যেহেতু hypoxanthine basically xanthine oxidase enzyme ke inhibit korche, tai jonno during its treatment hypoxanthine and xanthine level are increased, and because of feedback inhibition, purine synthesis in the body decreases. Now, since xanthine and hypoxanthine, they are more water soluble, they do not precipitate in the joint, and precipitation and crystallization in urine do not occur. They are excreted from the kidney. Pharmacokinetics, 80% absorbed, not plasma protein bound, metabolized largely to alloxanthine. During chronic medication, যে পেশেন্টটা অনেক দিন থেকে অ্যালোপুরিনল আছে, they inhibit its own metabolism. তখন কি হয়, 1/3 of the drug allopurinol is excreted in urine. Interaction inhibits degradation of 6-mercaptopurine and azathioprine. Probenecid shortens the half-life of allopurinol, while allopurinol increases the half-life of probenecid. They can potentiate warfarin and theophylline by inhibiting their metabolism. Higher incidence of skin rash occurs when a patient on allopurinol therapy put on ampicillin. Adverse effect uncommon. Hypersensitivity reactions are the most common side effect. Rashes, fever, malaise and muscle pain. They subside on stopping the drug, but when a patient on allopurinol, they suffer hypersensitivity reaction, the drug should not be readmitted again because serious reaction may occur. Stevens-Johnson syndrome is a rare but serious side effect. Gastric irritation, headache, nausea, dizziness infrequent and do not require withdrawal. Liver damage rare. Precautions and contraindication: liberal fluid intake. They are contraindicated in hypersensitive patient. In the pregnancy and lactation, should be used cautiously in a patient with elderly children and in a patient with kidney or liver damage. Second line ta probenecid chilo, is the first choice drug in the treatment of chronic gout. Can be used in both overproducers or underexcretors. Can be used in renal insufficiency patient, and they are effective in patients even with kidney stone. More severe cases of tophi and nephropathy also respond well, but they are infrequently used in India. More used is febuxostat. Less effective in low GFR, inappropriate in stone formers. Now, second use, secondary hyperuricemia due to cancer chemotherapy, radiation, thiazides. Potentiate 6-mercaptopurine or azathioprine in cancer chemotherapy. Febuxostat is a newer non-purine xanthine oxidase inhibitor, equally or more effective than allopurinol. The hypersensitivity reactions are rare, should be stopped if occur, like that of allopurinol therapy. Now, liver damage is the most common side effect in contrast to allopurinol. Diarrhea, nausea, headache are usual side effects. They can potentiate the action of mercaptopurine, azathioprine and theophylline. So, should not be combined with these drugs. Alternative drug to allopurinol but should not be combined simultaneously. Now, they are not indicated in malignancy associated hyperuricemia. Allopurinol can be used in malignancy associated hyperuricemia but not febuxostat. NSAIDs colchicine cover should be provided for 1 to 2 months while initiating febuxostat or allopurinol or probenecid therapy. Pegloticase is also a uric acid synthesis inhibitor. এটা বেসিক্যালি একটা recombinant uricase enzyme রয়েছে. It is not present in human being normally. This enzyme convert uric acid to the allantoin. Allantoin is more soluble and it does not precipitate in the kidney or the urinary tract. It is excreted by them. So it is easily excreted by kidney. Humans lack this enzyme. It has to be administered intravenously every 2 weeks. The problem is that it's immunogenic. It increases high incidence of infusion reaction, including anaphylaxis. So it is reserved for rare cases of refractory symptomatic gout. Again, if the drug is used multiple times, because of generation of antibody, response gradually decreases. Caution: allopurinol as well as uricosurics should not be started during an attack of acute gouty arthritis. During initial 1 to 2 month period of treatment with these drugs, attack of acute gout during this period probably due to fluctuating plasma urate level favoring intermittent solubilization and recrystallization in joint. This period should be covered by NSAID or colchicine. এর আগে বললাম একটা patient of acute gouty arthritis, we first give an anti-inflammatory drug, let the inflammation subside, then we start a uric acid lowering drug, either uric acid synthesis inhibitor or a uricosuric drug, and under cover of it and under the cover of an anti-inflammatory drug for a period of say 1 to 2 months.
Type 3 hypersensitivity and delayed type is one, that is delayed type of hypersensitivity. So it will take time, but this type of hypersensitivity is of immediate reaction. Now this type 1 hypersensitivity, type 2 hypersensitivity, type 3 all are mediated by humoral immunity. All are mediated by humoral immunity. Humoral immunity, that is antibody mediated. But this delayed type is by CMI, cell mediated immunity. That means no antibody is related to this type of hypersensitivity reaction. Now, what are the antibodies in type 1 hypersensitivity? Usually IgE mediated. Type 1 is IgE mediated. Type 2 is especially IgG and sometimes IgM. Type 3, it is also IgG and IgM. Type 4, you know, there is no antibody, it is cell-mediated immunity by the cytokines. Now, type 1 hypersensitivity, it is again of two types. One is systemic involvement, another is local involvement. Systemic, which is called anaphylaxis. Anaphylaxis. It leads to shock. And local, it is called atopy. Everyone, please try to write this chart as it is in gist. It is in gist. Now, type 1 hypersensitivity, it is IgE mediated. There are two types, systemic involvement, one is local involvement. Systemic involvement is called anaphylaxis. Anaphylactic shock is there. What is this? Sudden, you know, karo penicillin allergy ache, karo sulfonamide allergy ache, karo chingurite allergy ache. So, if suddenly who is allergic, penicillin is injected, suddenly what will happen? There will be allergic manifestation, severe. There will be smooth muscle contraction, that is bronchoconstriction. So there will be asphyxia, no entry of oxygen, no exhale of the carbon dioxide, so accumulation carbon dioxide, and there is lack of oxygen. There will be severe vasodilation, which will cause shock, hypotension. So hypotension, asphyxia, these will cause severe shock, and if it is not corrected immediately, patient may die. So severe, this condition occurs in anaphylaxis type 1. But local, what is local? That is particular organ is involved, not whole system. As for example, তোমাদের অনেকেরই হয়তো আছে ডাস্ট অ্যালার্জি আছে, তো কারো কারো ধুলোতে অ্যালার্জি, একটু ঘর ছাড়লেই ধুলোতে কাশি শুরু হয়ে যায়, তাই তো? সাম হ্যাজ অ্যালার্জি অফ ড্যান্ডার, অ্যানিমালের ফারে কারো হয়। এই বসন্তকাল এখন কি হয়, অনেক ফুলের পোলেন ওড়ে, হ্যাঁ, সেই পোলেনও কারো অ্যালার্জি হয়, প্রচন্ড সর্দিকে, সবার হবে না, কারো কারো হবে। সো দ্যাট পারসন ইজ অ্যাটোপি, তার অ্যালার্জি আছে কোথায়? ইন দ্য লাং। So not whole system, it is local involvement, so it is called atopy, and it goes in family. কারো বলে না আমার সর্দির ধাত আছে, মানে ফ্যামিলিতে আছে, ছোটবেলা থেকে একটু ঠান্ডা লাগলেই হাঁচি কাশি শুরু হয়ে যায়, কারো হাসি শুরু হয়ে গেছে, ঠিক আছে? তাহলে এগুলো হচ্ছে it runs in the family. So atopy, it runs in the family. There may be sinusitis, rhinitis, কারো একটু অ্যালার্জি হলো, প্রচন্ড নাক দিয়ে জল শুরু হয়ে গেল, চোখ দিয়ে জল শুরু হলো, হাঁচি কাশি শুরু হয়ে গেল, হ্যাঁ, বাট ইট ইজ নট সিভিয়ার, তোমাকে ট্রিটমেন্ট করতেই হবে এমন না। বাট ইন কেস অফ অ্যানাফাইলাক্সিস, পেশেন্ট উইল ডাই ইফ ইউ নট ট্রিট ইমিডিয়েটলি, ঠিক আছে? নাও হোয়াট ইজ দ্য মেকানিজম? দিস ইজ IgE mediated, I have told. In case of allergy, two types of doses are required. One is first dose or initial dose. First dose or initial dose. Then second dose or shocking dose. ফার্স্ট ডোজ, ইনিশিয়াল ডোজ। প্রথম কারো একটা অ্যালার্জেন নাকে ঢুকলো, পোলেনে প্রথমে বা ডাস্টে, তার কি হবে? তার বডি ইজ সেন্সিটাইজড, দ্য সেলস উইল বি সেন্সিটাইজড ফার্স্ট টাইম। অ্যান্ড তোমরা জানো কি করে তারা স্টিমুলেট করে, যখন কোনো অ্যালার্জি আর অ্যান্টিজেন ঢোকে, দেন ইট স্টিমুলেটস T cell will ultimately by the help of interleukin 345 it will stimulate B lymphocytes. এই ফার্স্ট ব্যাচ তোমরা কোনো প্রবলেম হচ্ছে? প্লিজ ডোন্ট টক। সো Th cell which will stimulate B lymphocyte. B lymphocyte, you know, will stimulate or produce plasma cells and memory cells. Plasma cell will produce specific antibody towards that antigen, and there will be antigen reaction, and memory cells will be produced. In allergic condition also, by the first dose few antibodies are produced. What type of antibody here? It is IgE. In allergy, IgE, type 1 allergy, IgE is produced and few memory cells are produced. This is first. And for this allergy, mast cells are responsible. Mast cells and basophils are responsible, as it has biologically active substances, which is, histamine and heparin and serotonin. These are the first layer of biologically active substances. So by first dose they are acting but not severe. But by second dose, যখন বডি সেন্সিটাইজড হয়ে আছে, মেমোরি সেল ইজ রেডি, একদম কেউ এলেই মেরে দেবো, সব রেডি হয়ে আছে, ঠিক আছে, দেন ইফ ফার্দার second time same type of allergen is entering in our body, then second line of biologically active substances will be reduced. এর ভিতরে যে গ্রানুল আছে সেগুলো সব তখন বেরিয়ে আসবে। হোয়াট আর দ্য সেকেন্ড টাইপ অফ বায়োলজিক্যালি অ্যাক্টিভ সাবস্টেন্স কেউ জানো? তোমরা পড়েছো হায়ার সেকেন্ডারিতে এসব জানো, কিন্তু প্রোস্টাগ্ল্যান্ডিন, প্লেটলেট অ্যাক্টিভেটিং ফ্যাক্টর, হ্যাঁ, SRS, a slow releasing substance, everything will come out. But what is the mechanism? Suppose তোমরা সবাই পেছন থেকে দেখতে পাচ্ছ কিন্তু আমি জানি না, first time the antigen is entering. This is, suppose this is antigen, and it will this is mast cell and it has a receptor for immunoglobulin, and the antibodies are produced, and this is the antigen. But when second time antigen is coming, body is ready with antibodies, and second time there are biologically active substances, then what will happen? This is second time. There will be, this is the antigen, this is the cross linking of the antibodies. দেখো দুটোর সঙ্গে জুড়ে আছে. It will stimulate or activate the mast cell. এবার mast cell যেই দুটো মিলে এসে চাপ দিল, mast cells is activated. Okay, then what will happen? There will be increased calcium channel. ক্যালসিয়াম চ্যানেল খুব বেড়ে যাবে, তাতে কি হবে? there will be deganulation. এখান থেকে সব গ্র্যানুলগুলো বেরিয়ে আসবে, মাস্ট সেল থেকে প্রচুর গ্র্যানুল বেরিয়ে আসবে, which will cause allergic reaction. What will the function? It will act on the smooth muscles of bronchus. There will be bronchoconstriction. তোমার যদি গলাকেও টিপে ধরে তোমার কেমন লাগবে? ভালো লাগবে? লাগবে না, কারণ bronchoconstriction হলে কি হবে? there will be asphyxia. তুমি নিঃশ্বাস নিতে পারছো না, no entry of oxygen, no exhale of the carbon dioxide, so severe bronchospasm will cause asphyxia. Okay, next, that is these active substance will cause severe vasodilation. ব্লাড ভেসেল কি হয়, আমাদের প্রেশার দিয়ে পাম্প করে সমস্ত জায়গায় ব্লাড সার্কুলেট করে, অ্যালং উইথ ব্লাড অক্সিজেন অ্যান্ড নিউট্রিশিয়াস সাবস্টেন্স রিচেস এভরিহোয়ার। ওকে, বাট ইফ দ্যার ইজ ভেসোডাইলেটেশন, ব্লাড ভেসেল যদি ডাইলেটেড হয়ে যায় তাহলে প্রেশার ইজ রিলিজড, প্রেশার থাকছে না, তাহলে প্রেশার পাম্প করে করেই তো প্রেশার দিয়ে সব জায়গায় পাঠাচ্ছে ব্লাড, সো দেয়ার উইল নো প্রেশার, so hypotension. If it is severe hypotension, no passage of oxygen nutrition to other areas, so first there is asphyxia, there is severe vasodilatation and other platelet aggregating factor etc which will cause thrombus formation in the blood vessels, so there is also hampering blood supply. All these will cause severe shock, which may kill the patient immediately if not treated properly. Adrenaline injection ইত্যাদি যে কারণে ইনজেকশন দিয়ে পেশেন্টকে বাঁচানো হয়। So this is the mechanism of type 1 hypersensitivity. Then type 2 hypersensitivity. Type 2 hypersensitivity, it is cytotoxic or cytolysis. মানে বুঝতে পারছো, lysis of the cell and cytotoxic, toxicity to the cell. মানে it is not only the antigen but as excessive immune reaction there will be damage to the tissue also. এখানে hypersensitivity important, খারাপ কেন, not only destroying the antigen, it also destroying our tissue injuries there. How it is occurring, you know, mainly cytotoxicity is seen in blood transfusion. Blood transfusion, ব্লাড ট্রান্সফিউশন কি হয়, একজন থেকে ব্লাড একজনকে দেওয়া হয়। যদি তোমার যদি বি গ্রুপ থাকে, তোমাকে যদি এ গ্রুপের ব্লাড দেয়, হবে কি, কারণ এ গ্রুপ ইজ ফরেন টু ইউ, সো আওয়ার ইমিউন সিস্টেম উইল প্রডিউস অ্যান্টিবডি এগেইনস্ট দ্যাট অ্যান্টিজেন, সো দ্যার উইল অ্যান্টিজেন অ্যান্টিবডি রিয়াকশন, লাইসিস অফ দ্য সেল। বডিতে সিভিয়ার লাইসিস হবে, তাহলে কি হবে, যদি আরবিসি ভেঙে যায় তাহলে কি হয়, hemoglobin বেরিয়ে যায়, that will cause anemia, severe anemia. So that is cytotoxic or cytolysis causing hemolytic anemia. তাহলে সেকেন্ড টাইপ অফ রিয়াকশনে কি হয়, cytotoxicity or cytolysis. Main example is blood transfusion. Secondly, erythroblastosis fetalis. তোমরা নাম শুনেছো কি, erythroblastosis fetalis? এটা কি হয়, যদি if mother is Rh positive, suppose father is Rh negative, so in first pregnancy, if it is mother positive, fetus positive, no problem. If mother positive and fetus is carrying the father's negativity, so fetus is negative. Okay, first delivery may occur, no problem, but during delivery, if there is mixing of the blood of the fetus to the mother, that means negative to positive, what will happen, in mother immune system will produce antibody against that negative blood. Okay, so first pregnancy, no problem. If in the second pregnancy again next baby, next fetus carrying the father's negative, so in mother's body antibody is ready to kill the negative, so when negative blood will come, there will be antibody reaction and that is erythroblastosis fetalis. ফিটাসটার মধ্যে সমস্ত হেমোলিসিস হবে, ফিটাস মে ডাই. So this is RBC lysis. It is example of type 2 hypersensitivity. Now example, suppose you see this is RBC, these are the antigen on the surface. আরবিসির অ্যান্টিজেনগুলো সারফেসের উপরে থাকে। ইন টাইপ 2 অ্যান্টিজেনস আর on the surface, but type 1, 3, 4, all these are soluble antigens, not on the surface. Now this is the antigen on the surface, then what will happen? Immune system will produce antibody. So antibody is there, আর তোমরা কমপ্লিমেন্ট পড়েছো। কমপ্লিমেন্ট যখন অ্যান্টিজেন অ্যান্টিবডি মারামারি হয় তখন কে থাকে? কমপ্লিমেন্টও ছুটে আসে। কিন্তু যদি শুধু অ্যান্টিবডি ঢোকে, কমপ্লিমেন্ট উইল নট অ্যাক্ট। শুধু অ্যান্টিজেন, কমপ্লিমেন্ট উইল নট অ্যাক্ট। যখন দেখবে দুই বন্ধু মারামারি হচ্ছে, মারামারি শুরু হয়ে গেছে, তখন কমপ্লিমেন্ট আসবে। ঠিক আছে? সো when antigen antibody binding is there, then complement will come. Now antigen antibody complement, this is immune complex formed. ওকে, এই লাস্ট বেঞ্চে তোমরা কি এত দৌড়দৌড়ি কেন হচ্ছে? স্পেশাল কিছু হচ্ছে লাস্ট বেঞ্চে? ছুটি একেবারে আমি জানি না কত ইম্পর্টেন্ট কাজ হচ্ছে। ঠিক আছে, পড়ে নেবে নিজে। নাও if there is antigen antibody complement which is called immune complex formation, এই ইমিউন কমপ্লেক্স কি হলো? এগুলো কি বডিতে ঘুরবে? বডিতে ঘুরবে না। কি করে? আমাদের বডিতে কি আছে? স্ক্যাভেঞ্জার সেলস, দ্যাট ইজ ম্যাক্রোফাজ। ম্যাক্রোফাজ উইল এনগালফ। if it is macrophage, it will engulf it. নিজে ম্যাক্রোফাজ এগুলোকে খেয়ে ফেলে। ঠিক আছে? খেয়ে ফেলে, তখন আমাদের বডি ইজ ফ্রি অফ ইমিউন কমপ্লেক্স। নালে আমাদের বডিতে সারাক্ষণ অ্যান্টিজেন রিঅ্যাকশনে অনেক ইমিউন কমপ্লেক্স সার্কুলেশনে ঘুরতে থাকবে। ঠিক আছে? কিন্তু সেটা হয় না কেন? আমাদের ম্যাক্রোফাজ সেগুলোকে বা স্ক্যাভেঞ্জার সেল যা আছে তারা সব এগুলোকে খেয়ে ফেলে, তাই এটা হয় না। নেক্সট, another killing. So macrophage can kill this or engulf these immune complexes which is produced by type 2 hypersensitivity. And another system is there, that is NK cell. তোমরা নাম শুনেছো বা পড়েছো? NK cell, NK cell। এই সেলগুলো কেমন? নট লিম্ফোসাইট, নট বি লিম্ফোসাইট। এটা বি লিম্ফোসাইটের মতোও না, টি লিম্ফোসাইটের মতোও না, কিন্তু এর একটা পাওয়ার আছে। জাস্ট লাইক ম্যাক্রোফেজ, ইট ক্যান কিল অর ফ্যাগোসাইট দ্য ফরেন পার্টিকেলস। ইন টাইপ 2 hypersensitivity, when the antigen is large, অনেক বড়, ছোট ছোট অ্যান্টিজেন হলে এইভাবে ইমিউন কমপ্লেক্স ফর্মেশন হবে, ম্যাক্রোফেজ খেয়ে নেবে। বাট ইফ ইট ইজ লার্জ, লাইক হেলমিন্থ, যার ওয়ার্ম ইনফেস্টেশন হয়েছে, ক্রিমি হয়ে গেছে, বড় বড় অ্যান্টিজেন তো, অ্যান্ড আদার লার্জ সাইজ অ্যান্টিজেন, তখন কি হয়? সেই অ্যান্টিজেনের সঙ্গেও তখন অ্যান্টিবডি লেগে যাচ্ছে, অ্যান্টিজেন অ্যান্টিবডি কমপ্লেক্স, বাট ইট ইজ নট ক্লিয়ার্ড বাই ম্যাক্রোফেজ অ্যাজ ইট ইজ হিউজ। সাপোজ টিউমার নেক্রোসিস, আমাদের যখন টিউমার হয় তখন আমাদের বডি সবসময় চেষ্টা করে সেই টিউমারটাকে নেক্রোসিস করার জন্য। ঠিক আছে? তাকে ঝেড়ে ফেলার জন্য। এটাও অ্যান্টিজেন অ্যান্টিবডি কমপ্লেক্সের সাহায্যে এলিমিনেটেড হয় না, ম্যাক্রোফেজ খেয়ে শেষ করতে পারে না। ইন দোজ কেসেস NK cell comes. Okay, NK cell can attack the as it has receptor for antibody. অ্যান্টিবডির জন্য রিসেপ্টর আছে। when antibody is attached with the antigen and antigen is large in size, that can be engulfed by NK cell. ঠিক আছে? তাহলে অ্যান্টিজেন যখন খুব বড় সাইজের টিউমার আর graft rejection হয়, graft is foreign substance to our body, it may be rejected sometimes, that is done by NK cells. So this is type 2 hypersensitivity. Now I will go for type 3 hypersensitivity. Type 3 hypersensitivity, here is also antigen antibody reaction. Suppose this is antigen, this is, so it is antigen, this is antibody, so antigen antibody reaction and complement is required. So type 3 hypersensitivity, antigen antibody complement 3 parts are required and these immune complex, এটাকে পুরোটাকে কি বলা হয়, immune complex. And speciality of type 3 hypersensitivity, these immune complex will cause tissue destruction. সমস্ত hypersensitivity tissue destruction হবে. What is the mechanism here? এখানে কি হয়, যদি excess antigen, excess antibody, excess immune complex এত বেশি হয়ে গেছে, সেটা সার্কুলেশনে ঘুরছে, ঘুরতে ঘুরতে কোন একটা অর্গানে সেটা ডিপোজিটেড হয়ে যায়। তাহলে as for example in glomerular membrane of kidney, কিডনি তোমরা জানো গ্লোমেরুলার মেমব্রেন আছে, অনেক সময় কি হয় তার উপরে অ্যান্টিজেন অ্যান্টিবডি কমপ্লেক্স ডিপোজিটেড হয়, কিন্তু প্রচুর ডিপোজিটেড কি হয়, তাহলে কি হবে, there will be hampering of the function of that glomerulus, so lead to necrosis of that tissue, so tissue destruction. It is a type of autoimmune disease. তোমরা autoimmune disease জানো, when immune system is destroying not only the foreign substance but also the own tissue. নিজের টিস্যু কি মানে অটো টিস্যু, so this immunity will cause disease that is called autoimmune disease. And তোমাদের স্ট্রেপ্টোকক্কাস এখনো পড়ানো হয়নি তো, হয়নি, so one bacteria important streptococcus, তোমরা জানো সবারই সর্দি কাশি খুব হয়, and that is responsible for mainly streptococcus pyogenes. Streptococcus pyogenes তোমাদের পরে পড়ানো হবে. What is the peculiarity of streptococcus pyogenes? streptococcus এর অনেকগুলো লেয়ার থাকে, হ্যাঁ, M protein, then carbohydrate layer ইত্যাদি. What is the peculiarity? This layer has similarity with the human body. এটা একটা ব্যাকটেরিয়া, কিন্তু এই ব্যাকটেরিয়ার সঙ্গে আমাদের হিউম্যান বডির কিছু স্ট্রাকচারের সিমিলারিটি আছে, হ্যাঁ, কেমন সিমিলারিটি না, স্ট্রেপ্টোকক্কাস যে মেমব্রেন একটা লেয়ারের সঙ্গে আমাদের হার্টের ভালভের সিমিলারিটি আছে, তাহলে যখন আর কি সাইনোভিয়াল মেমব্রেনের সিমিলারিটি আছে, তাহলে যখন অ্যান্টিবডি উইল বি প্রোডিউসড এগেইনস্ট দ্য স্ট্রেপ্টোকক্কাস, সেম অ্যান্টিবডি উইল কিল দ্য স্ট্রেপ্টোকক্কাস অ্যাজ ওয়েল অ্যাজ ইট উইল অ্যাটাক আওয়ার হার্ট মাসল, কারণ সিমিলারিটি আছে। ও তো আমাদের ইমিউনিটি তো চোখ অত খোলা নেই, সে জাস্ট ফিল করে নেয় হোয়াট ইজ দ্য সিমিলারিটি, যে স্ট্রেপ্টোকক্কাসের সঙ্গে সিমিলারিটি হার্ট ভালভের আছে, হার্ট ভালভের সঙ্গেও ইনফ্লামেটরি রিঅ্যাকশন হচ্ছে, সো ড্যামেজ টু দ্য হার্ট ভালভ, দ্যাট ইজ রিউমাটিক হার্ট ডিজিজ। সো ইট ইজ এ কাইন্ড অফ অটোইমিউন ডিজিজ, আমার ইমিউনিটি আমাকেই ডিস্ট্রয় করছে, সো অটোইমিউন ডিজিজ ইট ইজ এক্সাম্পল অফ টাইপ 2 and mainly type 3 hypersensitivity. And in nephron there is also antigen antibody complement immune complex is deposited. This is also an example of post streptococcal glomerulonephritis, যখন স্ট্রেপ্টোকক্কাস স্পর্ন হবে তোমরা দেখতে পাবে, এবং ভেরি কমনলি এগুলো হচ্ছে তোমাদের শর্ট নোট আসে, হ্যাঁ, autoimmune disease and post streptococcal or non pyogenic infection of streptococcus. Streptococcus usually pyogenic infection করে, but it is not pyogenic infection. So glomerulonephritis. Next, there is simulated synovial fluid with the streptococcus. So antibody, our immune system will produce antibody against streptococcus as well as with the synovial fluid. So there is arthritis. Peculiar. So these are the autoimmune disease. Our immune system causing or producing antibody against our body and causing disease, so it is autoimmune disease. And these are there is another example, or you have heard serum sickness. তোমরা নাম শুনেছো serum sickness? serum sickness ধরো কারো টিটেনাস হয়েছে, টিটেনাস যেন খুব সিভিয়ার কন্ডিশন, টিটেনাস ক্লস্ট্রিডিয়াম টিটানি ব্যাকটেরিয়া, কারো টিটেনাস হয়ে গেল রোড অ্যাক্সিডেন্টের জন্য, সিভিয়ার স্প্যাজম, তার অ্যাসফিক্সিয়া হবে, নার্ভ ইনভলভমেন্ট হবে, সিভিয়ার কন্ডিশন। তুমি তখনই কিন্তু টিটেনাস টক্সাইড দিয়ে ট্রিট করতে পারবে না, তার বডি ইনভলভমেন্ট হয়ে গেছে, ইমিডিয়েট তাকে রেডিমেড ইমিউনোগ্লোবুলিন দিতে হবে এগেনস্ট টিটেনাস। হ্যাঁ, যাতে এত টিটেনাস অর্গানিজম ভেতরে হয়ে গেছে সেটা কিল করার জন্য আমার ইমিডিয়েট ইমিউনোগ্লোবুলিন পাঠাতে হবে, তৈরি করার জন্য টাইম দেওয়া যাবে না ইমিউন সিস্টেমকে। তখন কি করা হয়, সেই জন্য আগের দিনের সিস্টেম ছিল একটা বড় অ্যানিমেলকে নেওয়া হয়, হ্যাঁ, ঘোড়া, হর্সকে টিটেনাস ইঞ্জেকশন দেওয়া হলো, তাহলে কি হবে, হর্সের ইমিউন সিস্টেম উইল প্রডিউস অ্যান্টিবডি এগেনস্ট টিটেনাস, করবে তো, করবে। আর ঘোড়া তো বিশাল জিনিস, তার অনেক অ্যান্টিবডি হবে সেরামে। তা আগের দিনে কি করা হতো, সেই যার ইমিডিয়েট অনেক বেশি ইমিউনোগ্লোবুলিন দরকার তাকে হর্সের সেরাম এনে দিয়ে দিল, তাহলে ইমিডিয়েট অনেকখানি ইমিউনোগ্লোবুলিন পাওয়া গেল, পেশেন্টকে হয়তো বাঁচানো গেল। কিন্তু হোয়াট উইল হ্যাপেন আফটার ফিউ ডেজ, ঘোড়ার মানুষ কি এক, গাধা তো নয়, হ্যাঁ, তাহলে ঘোড়ার মানুষ যেহেতু এক না, ঘোড়া ইজ ফরেন, so the horse serum contains foreign proteins, the proteins which is foreign to the human body, so that human immune system of that human how to will produce antibody against that proteins of horse serum, যে horse serum যে বডিতে দেওয়া ছিল তার যে প্রোটিন তার এগেইনস্টে সেই পার্সনের অ্যান্টিবডি তৈরি হবে, প্রচুর অ্যান্টিজেন এসছে, প্রচুর প্রোটিন এসছে, প্রচুর অ্যান্টিবডি, সো সিভিয়ার অ্যান্টিজেন অ্যান্টিবডি রিঅ্যাকশন ইন দ্যাট পার্সন, সো সিভিয়ার ইমিউন কমপ্লেক্স ফর্মেশন, গাদা ইমিউন কমপ্লেক্স বডিতে ঘুরে বেড়াবে, হ্যাঁ, অত এক্সক্রিশনও হচ্ছে না, মাইক্রোবাস কে শেষ করতে পারছে না, অ্যান্ড ইট উইল বি ডিপোজিটেড ইন ডিফারেন্ট ভাইটাল অর্গানস, so patient will again suffer from another problem, patient will be sick, it is called serum sickness, serum দেওয়ার জন্য যে sickness হলো, okay. অ্যান্ড অটোইমিউন ডিজিজ ইম্পর্টেন্ট, তোমরা যখন মেডিসিন পড়বে, এখন তো সিস্টেম আলাদা হয়ে গেছে, মেডিসিন পড়বে তোমরা জানতে পারবে দেয়ার ইজ অটোইমিউন ডিজিজ, দ্যাট ইজ অটো অ্যান্টিবডি প্রডিউসিং এগেনস্ট কানেক্টিভ টিস্যু, দ্যাট ইজ SLE, SLE মিনস সিস্টেমিক লুপাস এরিথ্রোমেটোসিস, SLE, প্যান পলিআর্টেরাইটিস নোডোসা, এগুলো সব হচ্ছে আমাদের কানেকটিভ টিস্যুর এগেনস্টে আমাদের বডি অ্যান্টিবডি তৈরি করে, অ্যাজ দিজ অ্যান্টিবডিজ মে বি এক্সোজেনাস, যখন বাইরে থেকে ব্যাকটেরিয়া ভাইরাস ঢুকলো তার এগেনস্টে যেমন ইমিউনিটি তৈরি হবে, ইমিউন সিস্টেম অলসো প্রডিউস অ্যান্টিবডি এগেনস্ট দ্য নিউক্লিয়াস, আমাদের সেলের নিউক্লিয়াসে কি থাকে, DNA, সো অ্যান্টিবডি উইল বি প্রডিউসড এগেনস্ট DNA অফ আওয়ার ওন, তাহলে আমাদের DNA এর এগেনস্টে আমাদের বডি অ্যান্টিবডি তৈরি করবে অ্যান্ড উইল কজ ডিজিজ, দ্যাট ইজ অটোইমিউন ডিজিজ এগেনস্ট কানেক্টিভ টিস্যু, that is SLE, systemic lupus erythematosus, all these are example of type 3 hypersensitivity. Next comes type 4 hypersensitivity. All these may come as short note. Type 4 is very important short note, type 1 is very important short note, and occasionally type 2, type 3 also coming, and in oral it is very common question, hypersensitivity. So it is totally peculiar, it is cell mediated immunity is here, CMI, all these three are humoral, antibody mediated, it is cell mediated, and that cell is টি সেল, তোমরা জানো অনেক সাবসেট আছে টি সেলের, টি সি সেল, সাইটোক্সিক সেল, টি হেল্পার সেল, T memory cell, and another is T DTH cell. delayed type of hypersensitivity. Delayed type of hypersensitivity, a kind of T cell. Actually, this is a kind of Th1 cell. Sometimes it may be Th17 cell or cytotoxic cell, etc. Now, delayed type of hypersensitivity, and in this type for hypersensitivity, macrophage taking the main role. Macrophage taking the main role, and it is usually intracellular parasites, intracellular bacteria. ব্যাকটেরিয়া যখন আমাদের ব্লাডে ঢোকে, ব্লাডে মুভ করতে থাকে, সেটা লাংসে গেলে ইনফেকশন করলো, কিডনিতে গেলে ইনফেকশন করলো, কিছু কিছু ব্যাকটেরিয়া তাকে কি করে, আমাদের অ্যান্টিবডিও কি হয়, সার্কুলেশনে ঘুরতে থাকে, অ্যান্টিজেনকে পেলো, কপ করে ধরে মেরে দিল, ঠিক আছে। বাট হোয়েন অ্যান্টিজেন ইজ উইদিন দ্য সেল, ব্যাকটেরিয়া ইজ উইদিন দ্য সেল, কোন কোন ইন্ট্রাসেলুলার ব্যাকটেরিয়া আছে কেউ জানো? সেলের মধ্যেই থাকে মেইনলি, তাকে অ্যান্টিবডি মারতে পারে না, অ্যান্টিবডি পাচ্ছে না, তো সেলের মধ্যে ঢুকে আছে। যদি সেলের বাইরে থাকে তবে অ্যান্টিবডি তাকে ধরে নেবে, কিন্তু সেলের মধ্যে থাকে কি একটা বলতে পারো, জানো তোমরা? মাইকোব্যাকটেরিয়াম টিউবারকুলোসিস। হ্যাঁ, মাইকোব্যাকটেরিয়াম। তাহলে এমটিবি কারা কারা সেলের ভেতরে থাকে ইন্ট্রাসেলুলার? এমটিবি, এম লেপ্রি, মাইকোব্যাকটেরিয়াম লেপ্রি, ব্রুসেলা, লিস্টেরিয়া, মনোসাইটোজিনস। যদি ওরালে জিজ্ঞাসা করে, তোমাদের এগুলো সব পরে পড়ানো হবে। ইন্ট্রাসেলুলার ব্যাকটেরিয়া কি কি আছে? মাইকোব্যাকটেরিয়াম টিউবারকুলোসিস, মাইকোব্যাকটেরিয়াম লেপ্রি, ব্রুসেলা অ্যান্ড দেন লিস্টেরিয়া, মনোসাইটোজিনস। আরও আছে, দিস আর দ্য কমনস। তাহলে এরা কি করে সবসময় সেলের মধ্যে ঢুকে যায়। এবার অ্যান্টিবডি ক্যান নট কিল দিস অর্গানিজমস, সো হেয়ার সাইটোকাইনস আর রিকোয়ার্ড। এরা অ্যাসিডের মতো, অ্যাসিড ঢেলে পুরো সেলটাকে গলিয়ে দেবে, বলে না ঢাকি শুদ্ধ বিসর্জন। পুরো এই সেল শুদ্ধ, পুরো এই সেল শুদ্ধ, ব্যাকটেরিয়া শুদ্ধ, পুরোটাই লাইসিস হয়ে যাবে, ঠিক আছে। তাহলে এখানে কি হবে, এখানে কি হয়, ফার্স্ট ম্যাক্রোফাজ ইজ টেকিং দ্য অ্যান্টিজেন্স and it is going to lymphocyte TH. So it is APC. It is APC, antigen presenting substance. এই যে ম্যাক্রোফাজটাকে অ্যান্টিজেনটাকে ধরে নিয়ে যাচ্ছে, অ্যান্টিজেনটাকে ধরে নিয়ে বললো লিম্ফোসাইটকে তুমি খাও, নিয়ে এসছি খাওয়া, ঠিক আছে, হাতে করে ধরে নিয়ে চলে গেল। হ্যাঁ, সো ইট ইজ এপিসি, অ্যান্টিজেন প্রেজেন্টিং সেল। নিয়ে গেল কার কাছে? Th সেল, হেল্পার সেলের কাছে। Th সেল দেখলো এটাকে অন্যভাবে খেতে হবে, আমার অন্য সাবসেটকে রাখতে হবে, তখন সে কি করলো, সে এটাকে DTH কে ডাকলো, জানে এটাকে মারতে হলে DTH লাগবে, ঠিক আছে। হ্যাঁ, তাহলে এইখানে যে DTH সেলটা এলো, DTH সেল এলে কি হবে, এর যেই অ্যান্টিজেনটা পেলো এটা অ্যাক্টিভেটেড হয়ে গেল, এটা অ্যাক্টিভেটেড হয়ে গেল। যখন এই রেস্টিং, এখন সে কি আছে, রেস্টিং ফেজে ছিল, এটা চুপ করে বসেছিল, যেই একটা বাজে খাওয়া হয়েছে সে ভীষণ অ্যাক্টিভেটেড, ভীষণ রেগে গেছে, এবার মেরেই ফেলবো এই সমস্ত ভাবছে। তখন কি করছে, কি করে মারবে, ও জানে আমার ম্যাক্রোফেজকেই আমার স্টিমুলেট করতে হবে, হ্যাঁ, ওকেই শক্তি টক্তি দিতে হবে, ওকেই আমার বিভিন্ন রকম স্টিমুলাস দিয়ে ওকে আমার অ্যাক্টিভেট করতে হবে। তখন কি করলো, তখন এই অ্যাক্টিভেটেড লিম্ফোসাইট অনেকগুলো কেমিক্যালস ছাড়লো যা দিয়ে ওকে মারবে, যেন অ্যান্টিবায়োটিক দিতে মারা যাবে না, বিভিন্ন অ্যাসিড, বিভিন্ন রকম নাইট্রিক অ্যাসিড, সালফিউরিক অ্যাসিড, অনেক অ্যাসিড ফ্যাসিড ছাড়লো। কি কি সেগুলো? দ্যাট ইজ ওয়ান ইজ ইন্টারফেরন গামা। তোমরা মনে রাখবে এটা যখন ভাইরাসকে কিল করা হয়, এটা মাথায় রেখো, তখন ইন্টারফেরন গামা ইউজুয়ালি লাগে ফর কিলিং অফ ভাইরাস, অ্যাজ ভাইরাস ইজ অলসো ইন্ট্রাসেলুলার সাবস্টেন্স। হ্যাঁ, এখানে ব্যাকটেরিয়াগুলো ইন্ট্রাসেলুলার ব্যাকটেরিয়া, প্লাস যদি ভাইরাস থাকে তাতেও ইন্টারফেরন গামা। তখন ডিটিএইচ কি করলো? ইন্টারফেরন গামা ছাড়লো। আর কি ছাড়লো? টিএনএফ আলফা, টিউমার নেক্রোজিং ফ্যাক্টর আলফা। হ্যাঁ, এটাও ম্যাক্রোফাজকে স্টিমুলেট করবে। আর কি ছাড়লো? IL-2, IL-3। তাহলে কি কি ছাড়লো? IL-2, IL-3, দেন টিউমার নেক্রোজিং ফ্যাক্টর আলফা, ইন্টারফেরন গামা, দেন GM-CSF, গ্রানুলার মনোসাইট কলোনি স্টিমুলেটিং ফ্যাক্টর, দেন ম্যাক্রোফাজ মাইগ্রেশন ইনহিবিটরি ফ্যাক্টর, যাতে ম্যাক্রোফাজ যাতে না চলে যায় ওখানেই থাকে, এরকম অনেক ফ্যাক্টরই ছাড়বে টু স্টিমুলেট দিস ম্যাক্রোফাজ। এবার ম্যাক্রোফাজ রেগে গিয়ে এবার খুব অ্যাক্টিভ হয়ে গেছে, ম্যাক্রোফাজ খেয়ে শেষ করে দেবে, ভীষণ অ্যাক্টিভ হয়ে গেছে, রেগেও গেছে যে আমার এরকম অ্যাটাক করেছে। তখন ও কি ছাড়লো? কিন্তু অনেক রিসেপ্টর ছাড়লো টু অ্যাকসেপ্ট ইন্টারফেরন গামা। মেনি রিসেপ্টর, অনেক রিসেপ্টর তৈরি করলো অ্যাক্টিভেটেড ম্যাক্রোফাজ, মেনি রিসেপ্টর টু অ্যাকসেপ্ট TNF আলফা, ইন্টারফেরন গামা এটসেট্রা, অ্যান্ড অ্যাজ ওয়েল অ্যাজ প্রডিউসেস, যেটা ইম্পর্টেন্ট কি ছাড়ে সেটা হচ্ছে অক্সিজেন রেডিক্যালস। হ্যাঁ, অক্সিজেন রেডিক্যালস, রয়টায় তোমরা নাম শুনেছো, অক্সিজেন রেডিক্যালস। আর হচ্ছে নাইট্রিক অক্সাইড, NO, অল দিজ আর লাইটিক এনজাইমস। এত লাইটিক এনজাইম হয়ে গেল, পুরোটাই লাইসিস হয়ে গেল ম্যাক্রোফেজ যুদ্ধ। ঠিক আছে? সো ইন দিস লাইসিস নো অ্যান্টিবডিজ রিকোয়ার্ড। দেখো কোনো অ্যান্টিবডি লাগেনি, টোটালি সাইটোকাইন মিডিয়েটেড। So it is cell mediated immunity, but whole process takes some time, 48 to 72 hours, 2 থেকে 3 দিন। যেমন অ্যানাফিলাক্সিস রিয়াকশন বা যার ডাস্ট গেল সঙ্গে সঙ্গে হাঁচি শুরু হবে, এটা কিন্তু টাইম নেয়। সো ইট ইজ কল্ড ডিলেড টাইপ অফ হাইপার সেন্সিটিভিটি, কারণ এটা টাইম নিচ্ছে, ডিলে হচ্ছে। আর কি মনে রাখবে? এর জন্য যে লিম্ফোসাইট থাকে তার নাম হচ্ছে TDTH, ডিলেড টাইপ অফ হাইপারসেন্সিটিভিটি সেল। আর কি কি লাগছে এখানে? ইন্টারফেরন গামা, টিউমার নেক্রোজিং ফ্যাক্টর আলফা, IL-2, IL-3, GM-CSF, and MI, that is monocyte chemotactic factor, etc., etc. So this is delayed type of hypersensitivity. What is the importance? কেন টাইফয়েডটা এত ইম্পর্টেন্ট? এই যে ইন্টারসেলুলার অর্গানিজম কিল করে তার মধ্যে ইম্পর্টেন্ট কি? টিউবারকুলোসিস। হ্যাঁ, টিউবারকুলোসিসে আমরা একটা টেস্ট জানি, মান্টু টেস্ট, নাম শুনেছো? টিউবারকুলিন টেস্ট, শর্ট নোট আসে, মান্টু টেস্ট। দিস ডিপেন্ডস অন দিস ডিলেড টাইপ অফ হাইপারসেন্সিটিভিটি। চাইতে পারে টিউবারকুলিন টেস্ট অন মান্টু টেস্ট, MNTOUX, মান্টু টেস্ট। দেন লেপ্রোসির জন্য লেপ্রোমিন টেস্ট, দেন মন্টেনেগ্রো টেস্ট, আর কি ফ্রেই টেস্ট, এই সমস্ত আছে। সো মেইনলি হচ্ছে টিউবারকুলিন টেস্ট। টিউবারকুলিন টেস্ট কি হয়? পেশেন্ট হুই সেন্সিটাইজড, যার টিবি আছে, আমরা মান্টু টেস্ট করি ইন্ট্রাডার্মাল, মানে সাবকিউটেনিয়াস নয়, মানে স্কিনের ভেতরেই ইঞ্জেকশন দেওয়া হয়। কেন? কারো টিবি, তোমাদের মধ্যে কেউ হয়তো হাঁচি কাশি জ্বরে অনেকদিন ভুগছে, তার টিবি আছে কি না বোঝার জন্য কি মান্টু টেস্ট করা হয়। মান্টু টেস্ট কি? টিউবারকুলার অ্যান্টিজেন ইজ ইনজেক্টেড ইন্ট্রাডার্মালি। ঠিক আছে, মানে সাবকিউটেনিয়াস স্কিনের নিচেও নয়, মাসলেও নয়, ইন্টারভিনাস নয়, ইন্ট্রাডার্মালি, অ্যাজ ইট ইজ আস্কড ইন দ্য ওরাল, অ্যান্ড শর্ট নোট ইজ কামিং অলসো। ইন হুইচ পেশেন্ট হুইচ সেন্সিটাইজ, যার টিবি আছে, তার কি হবে? বডি সেন্সিটাইজড, DTH সেল ইজ প্রেজেন্ট ইন দ্যাট পারসন। যখন তুমি ইনজেকশন এখানে দিলে কি দেওয়া হয়? পুরো টিবি ব্যাসিলেই দেওয়া হয় না, PPD, পিউরিফাইড প্রোটিন ডেরিভেটিভ, টিবির যে পোর্শনটা অ্যান্টিজেনিক সেটা নিয়ে ইনজেকশন দেওয়া হলো। সো অ্যাজ ইট ইজ ডিলেড আফটার 48 to 72 আওয়ার্স, কি হবে? এখানে যে লোকাল যে ম্যাক্রোফাজ আছে, যেমন কি আছে স্কিনে? ল্যাঙ্গারহ্যান্স সেলস। হ্যাঁ, সেগুলো কি করবে? সেগুলো ওই অ্যান্টিজেনকে এনগাল্ফ করবে বা ইন্টারনালাইজ করবে, সেটা নিয়ে গিয়ে তারপরে সে কি করবে? ম্যাক্রোফাজ করবে, কার কাছে চলে যাবে? ম্যাক্রোফাজ চলে যাবে কার কাছে? ডিটিএইচ সেলের কাছে। কারণ পেশেন্টের টিবি আছে, তার বডিতে ডিটিএইচ আছে, না থাকলে কোনো রিয়াকশন হবে না। তাহলে যেই ডিটিএইচ সেলের কাছে যাবে তখন কি করবে? সে অনেক সাইটোকাইন রিলিজ করবে। ওই বললাম যে সমস্ত রিলিজ করে, অক্সিজেন রেডিকেল, দেন নাইট্রিক অক্সাইড, দেন ডিফারেন্ট রিসেপ্টর ফর দ্য টিউমার নেক্রোসিং ফ্যাক্টর। ফলে কি হবে? একটা এখানে লোকাল একটা রিয়াকশন হবে। হ্যাঁ, রিয়াকশন হবে, সেখানে পেইন হবে, সোয়েলিং হবে, হার্ডনেস হবে। যার মান্টু তোমরা যদি চাও মান্টু টেস্ট করতে পারো, যার দেখবে এখানে শক্ত হয়ে গেছে, ফুলে গেছে, হ্যাঁ, পেইন হচ্ছে, হি সাফারিং ফ্রম টিউবারকুলোসিস। হ্যাঁ, হয়তো মাইল্ড, তুমি জানো না। আর যার নেই তার কিছুই হবে না, বাট ইট উইল হ্যাপেন আফটার 48 to 72 hours. So it is called tuberculin test. লেপ্রোবিন টেস্টও লেপ্রোসি থাকলে তারও ওই একই রকম ভাবে হবে। আর হচ্ছে টিউবারকুলোসিস যখন পড়ানো হবে তোমরা দেখবে গ্র্যানুলোমা ফর্মেশন কি করে হয় সেটা বলবে, সেটা তোমাদের শেখানো হবে। গ্র্যানুলোমা ফর্মেশন, লাংসে গ্র্যানুলোমা হয় কি করে হয়? সেটা হচ্ছে একই রিয়াকশন, ম্যাক্রোফেজ is taking the most important role. Macrophage is converted in different shape and size and different types of function. Suppose this is macrophage cell. These are macrophage cell. Some macrophage cells are converted into elongated fibroblast. Not sorry, fibroblast. That is fibroblast না, সেটাকে বলা হচ্ছে epithelial cell. Sorry, epithelial cell. Epithelial cell-এর মতো দেখতে. So it is called একই macrophage converted into epithelioid cell. অনেকগুলো epithelial cell নিজেরা কোয়ালেস করলে কি হয়? যদি মিশে যায়, it forms multinucleated giant cell. অনেকগুলো epithelial cell মিশে এক হয়ে গেল, অনেকগুলো নিউক্লিয়াস হয়ে গেল, then it is called multinucleated giant cell. সেন্টারে এটা থাকে, পেরিফেরিতে epithelial cell থাকে। তার বাইরে কি থাকে? অ্যাক্টিভেটেড ম্যাক্রোফাজ গুলো থাকে। যখন যারা এখনো কনভার্টেড হয়নি, অ্যাক্টিভেটেড ম্যাক্রোফাজ। সবার বাইরে কি থাকে? এই ডিটিএইচ সেল, লিম্ফোসাইট গুলো। ডিটিএইচ, ঠিক আছে? আর সবার বাইরে কি থাকে? কানেকটিভ টিস্যু। কানেকটিভ টিস্যু ঘিরে একটা শক্ত গোল মতো জিনিস লাংসে হয়। হ্যাঁ, দ্যাট ইজ কল্ড গ্র্যানুলোমা। গ্র্যানুলোমা ফর্মেশন, যেটা তোমরা এক্সরে করেও দেখা যায়, গ্র্যানুলোমা ফর্মেশন হয়। আচ্ছা, আর একটা এক্সাম্পল হচ্ছে ডিলেড টাইপ অফ হাইপারসেন্সিটিভিটি। কেন এটা বলছি? কারণ ভীষণ ইম্পর্টেন্ট শর্ট নোট হচ্ছে টাইপ 4 হাইপারসেন্সিটিভিটি, ডিলেড টাইপ। কি হয়? কন্ট্যাক্ট ডার্মাটাইটিস। কন্ট্যাক্ট ডার্মাটাইটিস তোমরা অনেকে দেখেছো যারা ব্যাঙ্গেল ট্যাঙ্গেল ইউজ করো মেটালের, হ্যাঁ, কারো কারো মেটাল সহ্য হয় না, সোনা বা রূপো ছাড়া, হ্যাঁ, অমনি অ্যালার্জিক রিয়াকশন হয়। হ্যাঁ, কারো হয়, আংটি পরলে যদি সোনা রূপো বাদে অন্য কিছু পরে, নিকেল বা অন্য কিছু, তার অ্যালার্জিক রিয়াকশন হয়। সো এই মেটালের কন্ট্যাক্টে দেয়ার ইজ ডার্মাটাইটিস। ঠিক আছে? কেন এই ডার্মাটাইটিস হয়? দিস কিংবা কিছু পয়জনাস কিছু লাগলো, সেখানে ডার্মাটাইটিস হয়ে যায়। কেন হয়? দিস nickel or metal, these are hapten. Hapten মানে incomplete antigen. It is not immunogenic. It cannot produce or stimulate immune system to produce antibody. But in contact, যখন এই ব্যাঙ্গেলটা যখন আমার স্কিনের কন্ট্যাক্টে এলো, এই নিকেলটা যেটা আমার সহ্য হয় না, অ্যালার্জি হচ্ছে, কেন না এই নিকেলটা স্কিনে অ্যাবজর্ব হলো। অ্যান্ড স্কিন হ্যাজ সাম প্রোটিন, স্কিনে প্রোটিন থাকে। those are carrier proteins. সেই ক্যারিয়ার প্রোটিন যখন এই হ্যাপটেনের সঙ্গে জুড়লো, নাও ইট ইজ ইমিউনোজেনিক। ঠিক আছে, হ্যাঁ, নাও ইট ক্যান প্রডিউস অর স্টিমুলেট ইমিউন সিস্টেম টু প্রডিউস অ্যান্টিবডি অর টু প্রডিউস সাইটোকাইন এগেনস্ট দিস। তার স্কিনে কি হচ্ছে, সো by nickel, which is hapten, and skin protein, which is carrier, hapten and skin protein carrier both becoming antigenic, and then it is immunogenic. তখন কি হলো, এখানে অ্যান্টিবডি টাইপ 4 হবে না, কি হবে, লোকাল কি আছে, ল্যাঙ্গারহ্যান্স সেলস আছে। অ্যান্টিজেন যেই পেলো, এখানকার ল্যাঙ্গারহ্যান্স সেলসগুলো ছুটে এলো, একে এসে এগুলো এনগাল্ফ করলো, যাকে বলা হয় ইন্টারনালাইজ, নিজের ভিতরে নিয়ে নিল ওটাকে। যেই এটা নিয়ে নিল, অমনি টাইপ 4 রিয়াকশন শুরু হয়ে গেল। ও নিয়েই তাড়াতাড়ি ছুটলো টিএইচ সেলের কাছে, ডিটিএইচ সেলের কাছে, যে দেখো অ্যান্টিজেন পেয়েছি, শিগগির এটাকে খাও, এটা মেরে ফেলো। তখন ডিটিএইচ সেলের কাছে যখন গেল, ডিটিএইচ সেল again it becomes activated by seeing the antigen, and it will produce the tumor necrosis factor and interferon gamma, etc. And it is activated, it will also activate that macrophage, and whole thing will end into cytolysis, সব কিছু মিলে ভেঙে চুরে যাবে। and there will be inflammatory process, নিউট্রোফিল লোকাল সেগুলো আসবে, সেখানে সেই ইনফ্লামেশনের জন্য কি হবে, সেখানে সোয়েলিং হবে, হার্ডনেস হবে, পেইন হবে, রেডনেস হবে। এই জন্য যারা ওই ব্যাঙ্গেল ট্যাঙ্গেল পড়ে, সেখানে কিছু পাস পয়েন্ট হয়ে যায়, পেইন হয়, আলসার হয়। So this is contact dermatitis. It is example of type 4 hypersensitivity. This is all. তো আমরা একটুখানি স্লাইড দেখে নিতে পারি। So definition, injurious consequences in the sensitized host. So ultimately there will be injurious fate. So it is hypersensitivity activation. It is not protective. শুধু বডিকে প্রোটেক্ট করছে না, আলটিমেটলি ইনজুরি করে দিচ্ছে টিস্যুকে, হাইপারসেন্সিটিভিটি। সো ইনজুরিয়াস এফেক্ট, টাইপ 1, টাইপ 1, টাইপ 2, টাইপ 3, টাইপ 4। Type 1 humoral, type 2 humoral, type 3 humoral, type 4 cell mediated. Okay, the immediate, it is delayed. It is within 2 to 30 minutes, খুব ইমিডিয়েট, সঙ্গে সঙ্গে হয়ে যেতে পারে, but it 24 to 72 hours. It is mediated IgE, এটা মনে রাখতে হবে, টাইপ 1 হচ্ছে বাই IgE, ভীষণ ইম্পর্টেন্ট অ্যানাফিলাক্টিক রিঅ্যাকশন, IgE, and this is IgG, this is antigen antibody complement process, that is immune complex, and it is TDTH cell, delayed type of hypersensitivity cell. Manifestation in type 1, there is anaphylaxis, in local asthma, যাদের অ্যাজমা হয়, ঠান্ডা লাগলে এইবার অ্যাজমা শুরু হয়ে যায়, তেমন লোকাল রিয়াকশন, দোজ আর অ্যাটোপিক কন্ডিশন, এটা হেরিডিটারি বংশে থাকে, and this is due to allergic reaction, type 1 hypersensitivity. Atopic dermatitis also, eczema যাদের হয়, eczemaটা হচ্ছে type 1 hypersensitivity. Type 2 ADCC mediated, complement mediated, and example is transfusion reaction, RH incompatibility, hemolytic anemia. And type 3 Arthus reaction, serum sickness, I have explained you, and glomerulonephritis, rheumatoid arthritis. Type 4, that is tuberculin test, granuloma formation, leprosy, contact dermatitis. You see the just pictures. Type 1 hypersensitivity, you can see type 1 hypersensitivity. This is the allergen. This is TH2 cell, and it is differentiation of the TH cell. Again, stimulation which will cause plasma cell formation, memory cell. This is first time. Plasma cell formation which will produce allergic specific IgE, This is first time, and memory cells are produced. These are the sensitized mast cell. Then re-exposure, that is second dose or shocking dose. What will happen? There is cross linking. দেখো দুটোর সঙ্গে জুড়ে আছে. It will stimulate this mast cell. There is increased calcium channelization, which will cause degranulation. এর থেকে গ্র্যানুলগুলো সব বেরিয়ে আসবে, ওই বায়োলজিক্যালি অ্যাক্টিভ গ্র্যানুলস, which will cause smooth muscle contraction, bronchospasm আমি বলেছি. আর কি করবে? ব্লাড ভেসেল ডাইলেশন, সিভিয়ার হাইপোটেনশন, আলটিমেটলি there will be shock. Allergic rhinitis, you know, I have told asthma, food allergy, atopic dermatitis, allergic eczema, drug allergy, all these are type 1 hypersensitivity, local reaction. স্কিনে অ্যালার্জিক টেস্ট এইভাবে করে. Type 2 hypersensitivity. Now you can see type 2 hypersensitivity on RBC. These are the blood group antigen, that is foreign blood group. So now this RBC is target cell. I have to kill this as it is foreign. It may be drug coated, so antibody is added. So antigen, antibody, complement also added. Complement, you know, it has classical pathway. Complement 1 এর পরে কি আসে? Complement 2 কি আসে? 4 142 1 4 2, তারপরে 3 আসবে, 5 আসবে, ইত্যাদি. ঠিক আছে? সো 1 4 2 3 142, তারপরে 35 মনে রাখো, 3 5, তারপরে 5 to 9. আলটিমেটলি কি করবে? ম্যাক ফরমেশন, মেমব্রেন অ্যাটাকিং কমপ্লেক্স. সবাই মিলে একটা মেমব্রেনটাকে, মানে সেল মেমব্রেনটাকে অ্যাটাক করার জন্য একটা কমপ্লেক্স, সবাই মিলে জোট বাঁধলো, সবাই মিলে সেল মেমব্রেনকে অ্যাটাক করবো. যদি একটা ডিমকে তুমি অ্যাটাক করো, খোঁচা দাও, গুঁতো, কি হবে? ফেটে যাবে. ফেটে গেলে কি ডিমটা নষ্ট হয়ে গেল? তাই সেলের মেমব্রেনের প্রতি সবাই মিলে অ্যাটাক করে, তাহলে কি হবে? সেলটাও ফেটে যাবে, সেল লাইসিস হয়ে যাবে. সেম প্রসিডিওর. And then what is happening? Ultimately antigen antibody complex is engulfed by the macrophage. ADCC সেল বলেছিলাম অ্যান্টিজেন ডিপেন্ডেন্ট সাইটোটক্সিসিটি. যখন অ্যান্টিজেনটা অনেক বড়, তখন শুধু অ্যান্টিজেন অ্যান্টিবডি কমপ্লেক্স কমপ্লিমেন্ট দিয়ে সেটা এনগলভড হয় না. তখন কি হয়? ইট রিকোয়ার্স দ্য হেল্প অফ NK সেল. So this is the target cell, বড় একটা target cell. Target cell, these are the antigen presenting sites. Antibodies are attached here. Now this NK cell, which is receptor for antibody, এটা কি করবে? পুরোটাকে engulf করে নেবে. So it is ADCC, antibody dependent cell cytotoxicity. চলে গেল. There is vasculitis. It is the example of type 3 hypersensitivity. These are the antigens. This is antigen antibody complex, and this is antigen antibody complex, and complement also taking part, and platelet also taking part by the help of PAF, platelet activating factor. সবকিছু মিলে কি করবে? টিস্যু ইনজুরি. দেখো এন্ডোথেলিয়াল লাইনিং এর ইনজুরি হয়ে গেছে. সো when there is injury in the blood vessel, what is called? Vasculitis. Vasculitis, blood vessel inflammation. Vasculitis, it is example of type 3 hypersensitivity. type 4 hypersensitivity. Last, you can see this is the APC, antigen presenting cells, intracellular bacteria. Intracellular bacteria, it is presented to the lymphocytes. It converted into T-DTH cell. দেখছে আমি পারবো না, DTH cell পারবে, T-DTH cell. Now DTH cell, now it is sensitized. যদি আগে থেকে ডোজ দেওয়া থাকে তাহলে now it is sensitized. Sensitized হওয়ার পরে কি কি ছাড়ছে? ইন্টারফেরন গামা, TNF বিটা, কাকে দিল না ম্যাক্রোফেজকে। এন্ড নাও ম্যাক্রোফেজ দেখো বড় হয়ে গেছে, ফুলে গেছে রেগে, হ্যাঁ, তাহলে এটা তখন অ্যাক্টিভেটেড হয়ে গেল। এ কি কি ছাড়লো? ইট TNF রিসেপ্টরস, যাতে TNF অনেক বেশি ধরতে পারে, প্রচুর রিসেপ্টর ছেড়ে দিল। অ্যান্ড ইট অলসো produces oxygen radicals, nitric oxide. All these are lytic enzymes. It will ultimately kill the whole thing.
Is more important for basically it's a base. When you learn this, this will be the base for your systemic pathology, because systemic pathology, there are mainly cancers, lots of cancers. So questions from this topic are asked in systemic pathology. Get it? Most students were not able to answer these questions for some reason, because most students during this semester did not listen to this class, right? It's a bit difficult. I find it difficult also, and it's more of research level, like not really related to treatment per se. But you have to know this, you have to understand this, and cancer research is progressing at a very fast rate because all the money is in cancer, right? So like maybe drugs for some of the factors are not available right now, but these drugs will be available say within 2-3 years or 5 years maybe. Research is going on these topics. So you have to understand this so that you can practice this later on in life. Okay. Questions per se from this topic are less, maybe short notes, not long questions usually. But questions are very unpredictable, so you may get questions also. Now, what lies at the heart of carcinogenesis? Non-lethal genetic damage. That lies at the heart of carcinogenesis. You know what is carcinogenesis? Yes, development of cancer. So, non-lethal genetic damage. What does that mean? That there is a genetic damage. There is damage to the DNA or the chromosome in the cell, which did not kill the cell. It's like, duh, right? Obviously, it did not kill the cell. That is why the cell could transform. If it already did kill the cell, then we would not have the cancer problem. So non-lethal genetic damage lies at the heart of carcinogenesis, and cancer develops over many years. Like even seemingly cancers which appear out of the blue and are very aggressive, say a child is suffering, a 10-year-old child is suffering from ALL, very common and very aggressive also. But even if we study that child, we may find cancer cells 10 years, a decade prior to the first appearance of symptoms or the first appearance of the signs of cancer or the cells of cancer in the peripheral blood. We may find, or even the bone marrow, we may find these cancer cells in the body of the child. So basically, it took a long time to develop, but we were not able to detect because there were no symptoms or anything, right? So what happens? And also cancer develops from a single cell, always. A single cell develops unrestricted replicative potential. What does that mean? There is no regulation to its replication, to its dividing. The cell goes on dividing. It does not listen to any checkpoints. It does not stop. So unrestricted replicative potential is acquired by a single cell. This cell then goes on dividing, and more mutations are acquired by this cell. Say one cell has divided into 2, exponentially it's growing, right? 1 to 2, 2 to 8, like that. And after that, some of the cells develop subclones. So there are more mutations in that cell. All the cells will have one same mutation, the mother mutation. That is called a driver mutation. That mutation will be present in all the cells. But apart from that, there will be more mutations. The cells acquire more and more and more mutations, and there are subclones. And then the tumor develops. So only one mutation is usually not found in a cancer. There are many mutations. So this is, say, a normal cell. Now the normal cell, and these are the carcinogens. You have had the class on carcinogens? So carcinogens can be chemical, can be infection, can be ultraviolet radiation, radioactive material, or even bad luck. That can also be there, right? So there is DNA damage. Now the cell is defective. Now the cell will multiply, and all these cells have the same DNA damage. See, they look same. All these cells have the same DNA damage. This I've already explained. Non-lethal genetic damage lies at the heart of carcinogenesis. So it can be either genetic point mutation or chromosomal aberration. This also you know, right? How are point mutations detected? Okay. There can be either point mutations or chromosomal aberrations, or chromosome translocations and all that, or there can be amplification. All these can give rise to transformation of a cell, and it can be spontaneous or random, or it can be germline. What is meant by germline? What is meant by sporadic? These terms you have to know. What is germline mutation and what is sporadic mutation? Okay, have you heard of HNPCC? Yes. So it can be germline or it can be sporadic. That means, have you heard of Lynch syndrome? Lynch syndrome, ম্যারোতে, এগুলো তো না জানলে তো একেবারেই র্যাঙ্ক হবে না। তো Lynch syndrome is again gives rise to HNPCC. There are 4 genes mainly: MSH1, MSH2, PMS2, MSH6. Now this can be inherited in a germline fashion, inherited in a familial way. The parents are suffering from Lynch syndrome, the offspring may suffer from Lynch syndrome. So that is germline mutation. Another person at random may get mutation in these same genes. These are mismatch repair genes. A person may acquire mutation in mismatch repair genes, but his parents or his offspring will not suffer from this. Then that becomes sporadic. This is the difference between germline and sporadic. Have you understood? Another example? Germline means familial. Family te run kore. Like breast cancer syndromes, autosomal dominant, hereditary gastric cancer syndrome, lots of syndromes. Lee-Fraumani syndrome, thousands of syndromes. Peutz-Jeghers syndrome. Peutz-Jeghers you have heard of? Hereditary retinoblastoma, autosomal dominant hereditary retinoblastoma. That is also there. RB gene mutation. So anyway, so these are examples of germline mutation. I will come to this, don't worry. So these are the germline mutations, or it can be sporadic also, like acquired mutation during the lifetime because of bad luck, because of radiation, because of anything. Now, this also a tumor is formed by the clonal expansion of a single precursor cell that has incurred genetic damage. Now, this genetic damage is passed on to daughter cells. So, this is the normal cell. This has incurred the genetic change. This becomes the cancerous cell. Now, this cancerous cell is now replicating and giving rise to the malignancy. So, all these cells carry the precursor genetic damage. This can be point mutation detected by DNA sequencing or copy number variation detected by chromosomal analysis. This was the question I asked, right? So, in cancers, there can be point mutations, right? Or there can be copy number variations also. Example is uterine cancer. Uterine cancer, the endometrial cancer, endometrium, mostly we get adenocarcinoma. Right, endometrial has a lining, right, that is glandular lining. So, this gives rise to adenocarcinoma. Now, this adenocarcinoma can have point mutations or these copy number variations, right. This is an example. Many cancers have this, but this is the most popular example. Now, 4 classes of genes are principal targets of cancer-causing mutations. Growth-promoting proto-oncogenes. Do you know what are proto-oncogenes? Yes. Proto-oncogenes are basically the normal counterparts of oncogenes, right? So, when they are mutated, when the proto-oncogenes are mutated, they give a lot of growth signals to the cell and the cell goes on dividing. Unrestricted growth signals are given to the cell and the cell goes on dividing. These are the oncogenes, right? So, the proto-oncogenes are the precursors. Now, when the proto-oncogene is damaged, it gives rise to the oncogene. The oncogene gives rise to the product of the oncogene, which are usually growth signals to the cell, right? Growth inhibiting tumor suppressor genes. Now, what are tumor suppressor genes? What do they do? What is the function of tumor suppressor genes? Suppress the growth of tumor, right? So, in almost 95% of cancers always have a mutation in the tumor suppressor gene. As I said that cancer may have developed from another, say, oncogenic mutation was there. But if we study that tumor cell, we will always find that P53 is also mutated in that cell. Right, P53 will always be mutated because otherwise the tumor would not be able to develop. P53 would be able to control the growth of the tumor cell. P53 is mutated, that is why the tumor could develop. Right, it is called, that is why it is called the P53 is called the guardian of the genome. Right, so these are the tumor suppressor genes. Genes that regulate programmed cell death. What is programmed cell death? Apoptosis. Right. So, can you name a gene which regulates apoptosis? I will come to this although. Genes which regulate apoptosis. BCL. So, yes. So, if there is mutation in the BCL, so apoptosis is not happening and then tumor develops. There are 2 pathways, I will come to it. There are 2 pathways of apoptosis, intrinsic and extrinsic. Intrinsic pathway is damaged and apoptosis is not taking place. If a damaged cell is there but apoptosis is not taking place, what happens? The damaged cell goes on proliferating and develops cancer. Genes that are responsible for DNA repair. This I've already said. Which ones are those? Which one? I just said it. For DNA repair, Yes, but there are some genes which are called mismatch repair genes. এক্ষুনি বললাম তো mismatch repair genes. MSH2, MSH6, PMS2, MSH1. These are the mismatch repair genes. What happens when a cell is proliferating, the DNA is duplicating, there will be some mismatch. There will be some genetic aberrations. Now, these are repaired by this system, mismatch repair genes. When mismatch repair genes are mutated, that can also give rise to cancer like colorectal carcinoma. This was asked in the exam, colorectal carcinoma mismatch repair gene. Now, carcinogenesis results from the accumulation of complementary mutations in a stepwise fashion over time. Now, there can be some mutations which give rise to some phenotypic, like the phenotypes of the cancer are given by some mutations. That is the driver mutation. Like, say a cancer, say a prostate cancer can metastasize to the spine, right? Prostate cancer frequently metastasizes to the spine. So that is a driver mutation. The prostate cancer developed first. That was a driver mutation. In between, there will be lots of other mutations, which we will not be able to see. That will not give rise to a hallmark of cancer. The hallmarks of cancer, like angiogenesis or metastasis or unrestricted replication, these are the hallmarks of cancer. These are given by some driver mutations. So initially, the cell can only replicate. Then the cell goes on replicating, and there are more mutations in the cell. Some of these mutations are the driver mutations. Now, one of these mutations gives the tumor the power for angiogenesis. Now, the tumor gets more blood vessels, more nutrients. Now, then again, the tumor goes on growing. Now, one of the mutations gives it power to metastasize, and the tumors metastasize to a specific location. And remember, the tumor has to metastasize to an environment which is not favorable, say a breast cancer. Now, breast cancer has developed in the breast. It is a fibrofatty tissue. Now, this cancer, say, has metastasized to the lymph nodes, axillary lymph nodes. Now, the axillary lymph nodes is a different environment. The environment is of lymphocytes, right? So, it's a different microenvironment where the tumor has to adjust. So, that is another driver mutation which the cancer acquired. And only then was it able to go and home in another tissue, right? So, these are the driver mutations. These are the subclones of the cancer. But all the cancer cells, as I said, will have one specific mutation which first gave rise to the cancer. That mutation will be present in all the cells. But the cells which have metastasized have some new mutations which may not be present in the initiating tumor cells. Okay. Now, you may not be able to understand this, but when we see slides, say I got a slide of ovarian cancer. I am seeing it in the ovary. It looks different, even in histology, just light microscopy, H&E stain. It looks, say, in one way, but say the ovarian cancer has metastasized to the peritoneum. It looks also different. You will be able to appreciate it when you see the slide. So, it may have acquired, or it's not may have, it has acquired some other driver mutations which allowed it to metastasize to a different location and grow. Mutations that contribute to the acquisition of cancer hallmarks are called driver mutations. Hallmarks of cancer are features of malignant cells like excessive growth, local invasiveness, ability to form distant metastasis. Now, what is the difference between local invasion and distant metastasis? বলো, উঠে দাঁড়িয়ে বলো। বলো। What is the difference between local invasion and distant I mean, it's kind of there in the term only. Local invasion, distant metastasis. Then it is called distant metastasis. So these are the hallmarks of cancer. This process is lengthy and requires an unknown amount of time. Mutations can also be passenger mutations that are acquired due to genomic instability and appear to have no phenotypic consequence. This I have explained. Have you understood? Now, the process of cancer development is the same only. There is the initiated mutation, that is, the mutation is present in all subsequent cancer cells. Then there are passenger mutations, additional mutations that lead to genomic instability. Then there are additional driver mutations and tumor evolution by Darwinian selection. Now, this is present in your book. Like Darwin had proposed the theory of evolution in finches, right, of the Galapagos Island. So he had said that only survival of the fittest. So the finches which have some special characteristics are selected by nature and are able to survive. Similarly, cancer cells which have some special characteristics are able to survive in the environment. Say now a person is suffering from cancer and now is getting treatment, but we have heard of relapse. Why? After many years, the person gets a recurrence of that same cancer. Why? Because some of the cells have some mutations that were not targeted by the therapy. The cancer drugs that were given were not able to kill these cells because they have some special characteristics, right? So they were able to survive and there was recurrence, right? This is from Robbins. So this is the same thing basically. Carcinogen-induced mutation, initiated precursor with stem cell-like properties. Now the cancers have stem cell. What are stem cells? No, that is pluripotency and totipotency. What is stem cell? Death hobe na. Jei cell death hobe na. Stem cell-like properties. Initiated precursor, stem cell-like property, additional driver mutation, founding cancer cell, additional mutations, emergence of subclones. Now you can see the cancer ultimately is very heterogeneous genetically, right? What is meant by heterogeneity? All the cells don't have the same mutation. Some cells have more mutations. Am I boring you? Am I boring any of you? So now many of the cells have some other heterogenic capacities, have other properties. Now we get the ultimate, the cancer that we see is this. Yeah, because many of you seem sleepy. That's why I'm asking. I already told you this is a bit difficult and everything. So now these are the hallmarks of cancer. Self-sufficiency in growth signals. Insensitivity to growth inhibitory signals, growth promoting metabolic alterations, evasion of cell death, limitless replicating potential, angiogenesis, metastasis, evasion of immune surveillance, genomic instability, and tumor promoting inflammation. Now, what is meant by self-sufficiency in growth signals? The cancer cell itself gives out the growth signals for its own growth. It does not need growth signals from an external environment. It gives out its own signals for its own growth and it goes on replicating. Insensitivity to growth inhibitory signals. Now the cancer cells acquire properties where, say, there is a growth inhibitory signal, a signal which is asking the cell not to grow, but still it is ignoring that signal, it is going on growing. Growth promoting metabolic alterations, I will come to that. Evasion of cell death. because they have stem cell-like properties, so they can evade cell death. Limitless replicating potential, angiogenesis, you know. What is angiogenesis? New blood vessels, invasion and metastasis, evasion of immune surveillance, I will come to this. Now, genomic instability, you have already understood the driver mutations and passenger mutations, and the whole genome of the cancer is very unstable, and that is why it gives rise to newer mutations, and that is why it can have newer properties, which helps it to invade, it helps it to metastasize, it helps it to evade therapy. And there is also tumor promoting inflammation because cancer gives rise to a pro-inflammatory state, and then cancer patients present with cachexia. You know what is cachexia? Yes. So there is tumor promoting inflammation. Self-sufficiency in growth signals. Oncogenes are mutated genes that cause excessive growth even in absence of growth factors and other growth promoting external cues. This I've already said, you have understood. What are oncogenes? In the absence of external cues, they can go on growing. Last benchers, what is your name, madam? Please stand up. Yes. What are oncogenes? Yes, sir, beside you. What are oncogenes? অন্তত 3-4 বার 5 বার আমি অঙ্কোজিন বলা হয়ে গেছে এখন অবধি। See, that is why students are ultimately not able to answer in the papers. From this year onwards, you are not allowed to behave like this in class. Either you listen or you can leave it. I don't care how many students are attending. Things are being taught in the class and ultimately most students are not able to answer. That is because you don't care. You don't care what is being taught in the class. Sit down. It's even written here. They are mutated or overexpressed versions of normal cellular genes, the proto-oncogenes. These mutations increase or alter the function of the oncoproteins. The product of the oncogenes are called the oncoproteins. Now, these mutations increase or alter the function of oncoproteins. Cells expressing oncoproteins are freed from normal checkpoints and proliferate excessively. What are the checkpoints? G1S and G2M. So, these cells which express oncoproteins are freed from normal checkpoints and proliferate excessively. Now, the example. JAK-STAT pathway, you know, it was there in physiology. JAK-STAT pathway. Janus activated kinase. It's very important for all myeloproliferative neoplasms. Right? So, the JAK-STAT pathway and EGFR pathway. EGFR is important for lung carcinomas. Right? Whenever we report lung carcinomas, we always have to test for EGFR mutation, for RAS mutations, and also for PD-1, PD-L1 mutations. Because therapy is available against these. That is why whenever we report lung adenocarcinomas, we have to report this. Now, these EGFR, these are also, these give the growth signals. RAS is involved in many cancers, including melanomas. HER2, you know, HER2 is also called ERBB2, right? So, and EGFR is ERBB1. So, HER2 is responsible for breast cancer, right? You know this, HER2. Why do we test for HER2 in breast cancer? Because therapy is available, right? You know, Herceptin is available to treat HER2 mutated cancers. That is why we always test for HER2. Whenever we sign out a breast cancer, we test ER, PR, HER2 and Ki67. insensitivity to growth inhibition. And the next point, tumor suppressor genes. These suppress growth, right? Tumor suppressor genes. Now, tumor suppressor gene products apply brakes to cell proliferation or cause the cells to go into a post-mitotic differentiated state without further replication. This is the normal function of p53. It goes into a differentiated state. It does not divide, right? Now, the p53 is mutated. So, growth inhibition is not there. It's not growth promotion, it's growth inhibition. Growth inhibition is not there. Now, can you deduce what will be the difference between a cancer which lacks p53? There is growth inhibition is not there, as opposed to a cancer which has too much of growth promotion. What will be the difference in prognosis? Which will be more aggressive? The one which is going on replicating, or the one which is replicating at a slower rate because growth inhibition is not there? The second one. So this is what we get. Prognostic difference is there between these cancers. That is why we have to know when later on in life a patient comes and asks you, "Amar ei cancer tar prognosis ki rokom?" Then you can answer. Now, do you know about Knudson's two-hit hypothesis? Have you heard of Knudson's two-hit hypothesis? Do you know the function of RB gene? Retinoblastoma. It is called Knudson's two-hit hypothesis, right? So what happens? There is something, now RB gene mutation can give rise to retinoblastoma, also other soft tissue tumors, including osteosarcoma. Retinoblastoma mutation most commonly gives rise to retinoblastoma and osteosarcoma. Now, say there are two copies of the RB gene, right? Now, a person has inherited a defective copy of the RB gene. Before birth, one copy was, say, defective, okay? But the other copy is there, right? So, it should function. But what happens during even the first few years of life? This copy may get mutated, and it usually does get mutated, okay? So, first hit happened before the person was born. The second hit happened later on in life. Now, this is also gone. What is there? Retinoblastoma. So, most cancers develop in this way. Two hits are required. That is how the RB gene was the first gene which was studied. So, that is why this is most popular. You have to know this. Now, this was germline as opposed to now the persons who have this germline mutation of retinoblastoma have 10,000-fold increased risk of developing retinoblastoma as opposed to the normal population. In the normal population, retinoblastoma is not that frequent. It's not a very common cancer. But in people who have germline mutation of retinoblastoma, in them there is 10,000. 10,000-fold increase means they will get retinoblastoma. Say, now this person has normal copies of RB. And during lifetime, one copy was not there, but the other copy is there. So, this person will not get retinoblastoma. But again, further down the line, this person, this is also mutated. Only then this person will get retinoblastoma. This is what happens in the normal population. whereas in germline mutation, which gives rise to autosomal dominant retinoblastoma. Okay, that was autosomal dominant. So, RB gene defect gives rise to autosomal dominant. P53 is the guardian of the genome. P53 mutation is associated with a cancer syndrome. It is called Li-Fraumani syndrome. These are all MCQs. These were asked when I appeared. APC, do you know what is APC? For gene. APC gene is associated with colon cancer. If you're interested, I will tell you there are two pathways of development of colon cancer, right? One is the APC gene mutation adenomatous pathway, where there is APC gene mutation in chromosome 5q. This is an MCQ, right? So APC gene mutation gives rise to the adenomatous pathway of colon cancer. There is another pathway which is the serrated polyp pathway. Over there, the genes involved are the mismatch repair genes HNPCC and Lynch syndrome, right? So APC gene gives rise to colon cancer. NF1, NF2, you know? NF1, do you know what is NF1? মাথার উপরে যাচ্ছে ইচ্ছে করছে না কি neurofibromatosis, right? Neurofibromatosis syndrome. These are syndromic cancers. NF1, NF2. BRCA1, BRCA2, you know, breast cancer, right? This one you will not know. STK11, WT1 you have to know. It's there in your syllabus. WT1, Wilms tumor. MSH2, MLH1, I have said. VHL, you know? What is VHL? Von Hippel-Lindau disease. It gives rise to renal cell carcinoma. I used to take classes in DAMS. এগুলো সব মুখস্থ করা করিয়েছিল। তোমাদেরও করাবে eventually. Now, growth promoting metabolic alterations. This is very interesting. I find it very interesting. Growth promoting metabolic alterations. Now, cancer cells have a very unique property. Even in the absence of ample oxygen, cancer cells can divide, or they rather choose to divide in this way. Even in the absence of ample oxygen, they can go on dividing. Now, do you know what happens in the presence of oxygen? You've studied biochemistry. এইটা তো জানো, হ্যাঁ বলো। দুটো পাথওয়ে হয় অফ রেসপিরেশন, ক্লাস 11, 12, 6 ফিক্সে পড়েছে মনে হয়, রাইট? তো এরোবিকে কি হয়? কটা মলিকিউলস অফ এটিপি তৈরি হয়? 36. And the other pathway, anaerobic, and how many ATPs? 2, right? So now what happens in a differentiated tissue? We know this, respiration. So Krebs cycle hochhe oxidative phosphorylation, 36 molecules of ATP per molecule of glucose, and the এটা কি anaerobic glycolytic pathway, সেটাতে হচ্ছে 2 molecules of ATP. But cancer cells, but not only cancer cells, but highly replicating cells, both these. Cancer cells, but for our discussion, it's cancer cells, right? So what happens in cancer cells, even in the presence of oxygen or in the absence of oxygen, what they do is aerobic glycolysis. It produces 4 molecules of ATP per molecule of glucose. This is called aerobic glycolysis, 4 molecules of ATP per molecule of glucose. This is called the Warburg effect. Who is this? This is Otto Warburg. He got the Nobel Prize, I don't remember which year, for discovering this. This is very important in cancer cells. Right? Now, why do you think cancer cells are doing it? Why are they choosing not to metabolize, not to go through Krebs cycle and get 36 molecules of ATP? They are getting only 4 molecules of ATP. Why? Because they are now getting carbon moieties, right? These carbon moieties are now used to produce the cell organelles. For a cell to divide, only DNA replication is not enough. It needs all the organelles of the cell. A cancer cell has all the organelles, all the membranes, all the organelles. So for that, it needs carbon moieties. And that carbon moiety, it gets by this aerobic glycolysis, right? This property is also used in PET scan. You have heard of PET scan? When is it done? PET scan এর full form জানো? Positron emission tomography, right? What happens is it uses this same principle. F18 labeled glucose is injected into the patient. F18 labeled glucose. Now, this person is then scanned. This F18 labeled glucose is picked up. Now we can see where the cancer has gone. We can see the replication of the cancer cells. So, we need to detect a cancer which has metastasized or not, has recurred or not in a distant site. That's when we use the PET scan. বোঝা গেছে? বুঝেছো? Yes, no. So, I find this very interesting, this Warburg effect. This is used by cancer cells. Now, growth promoting metabolic alterations. Now, normally, there are extreme environmental conditions. Any cell, say, is not getting enough nutrients. The cell can then stimulate autophagy, where it ingests its own organelles. Cells can do two things. Either they can evade autophagy. This is a metabolic alteration in the cancer cell. It can evade autophagy. Even under extreme conditions, it can survive. So I told you, survival of the fittest. In the milieu of the body, cancer cell is actually the fittest to survive. Cancer cell will evade autophagy, number one. Or it can use it in a different way. Say, all the cancer cells are getting killed by therapy, by a drug. What the cancer cell will do is stimulate autophagy and go into a dormant state. Now, years later or months later, this cell will again start dividing and give rise to cancer again. So, this is how it evades therapy, right? Okay. Now, oncometabolism, this you just have to know. Oncometabolism, you just have to know the term. It is used by cancer cells where a special metabolite used in the Krebs cycle, isocitrate dehydrogenase mutation is there. This IDH mutation is very important for astrocytomas. Later on, when you study brain, you will study astrocytomas. This is very important in astrocytomas. This isocitrate dehydrogenase mutation is used where the products of this gene now will give rise to epigenetic alterations. What are epigenetic alterations? Do you know? After DNA replication, the DNA is packed by histones. This is called epigenetic alteration, where this histone packing is aberrant or DNA methylation is present. DNA after replication is getting methylated and aberrantly it is behaving. So this is called epigenetic alteration. You just have to know the term oncometabolism, that's all. evasion of cell death. Now, tumor cells frequently contain mutations in genes that result in resistance to apoptotic cell death, especially the mitochondrial pathway. Which I already told you, the extrinsic pathway and the intrinsic pathway. Intrinsic pathway is the mitochondrial pathway. So, it evades the mitochondrial pathway of apoptosis. This can occur by loss of TP53 or P53 function, or anti-apoptotic members of the BCL2 family are overexpressed, right? BCL2 is important for follicular lymphoma. This is also an MCQ. Translocation 14-18, this is asked. Follicular lymphoma te konta hoy? 14-18, 11-18, চারটে দিয়ে দেবে। সবকটাতেই লিম্ফোমা হয়। এবার বলো follicular lymphoma te konta hoy? This is a common MCQ and I always used to get it wrong. So anyway, translocation 14-18 gives rise to follicular lymphoma CLL. Here there is overexpression of anti-apoptotic BCL2 family. Now what do you think? Again, this gives rise to the prognosis, right? Say MYC. MYC is a gene? Yes. So which cancer is it associated with? It is associated with Burkitt's lymphoma, right? Now, MYC is an oncogene, right? So what it does is it goes on growing. So the proliferation in Burkitt's lymphoma is very high. It is a very aggressive lymphoma. Burkitt's lymphoma is very aggressive and death is more frequent as opposed to CLL or follicular lymphoma. These follow a more indolent course. The prognosis is better. Why? Because apoptosis, anti-apoptotic BCL2 is overexpressed. So apoptosis টা হচ্ছে না, তাই জন্য যে ক্যান্সারটা হচ্ছে সেটার প্রগনোসিসটা বেটার। And all these have targeted drug therapies. Now, do you know what are cancer cell lines? কেউ জানো না? Cancer cell lines. HeLa, Hep2, these are cancer cell lines. HeLa comes from Henrietta Lacks. This was an ovarian cancer cell line. Henrietta Lacks, she donated her cancer cells for research. So now these cells don't die. So all kinds of research, not only cancer research, all kinds of research is conducted on these cell lines. These cell lines will, they have, what your book says is they have found the proverbial fountain of youth. They will never die. These are called cancer cell lines, and as long as there are some scientists who are tending to these cell lines will always go, always stay alive, basically. So now all cancers contain cells that are immortal and have limitless replicative potential. Cancer cell lines are an example. Now, how do they do it? They evade senescence. Now, all cells, what happens is, a cell can maximum divide up to 60 to 70 times. After that, it will die. Like a normal human being can grow up to maybe 60, 70, 80 years depending on the life expectancy of the region, and then that person will die. Similarly, a cell can divide 60 to 70 times. After that, that cell will divide. That is helped by RBP53, etc. because of DNA damage. But a cancer cell will not die. RBP53 is also defective and the cell will not die. It is an inherent property of that cell. Apart from that, evasion of mitotic crisis. Do you know what telomerase does? I think I should have taken it in 2 classes. Do you know what telomerase does? Do you know what is a telomere? Yes, telomerase repairs the telomere. Now, all cells don't have telomerase, but the cancer cells do have telomerase. Many cancer cells have telomerase. So, what happens normally when a cell is dividing, the telomere shortens. Yes, you know this. The telomere shortens. So, the cell eventually dies. It goes into mitotic crisis and dies. But the cancer cell has telomerase. So it goes on manufacturing the telomere and the cancer cell can evade death. And there is capacity for self-renewal. Now, say this is the stem cell. This is giving rise to now say this blue one is the cancer stem cell. It is a stem cell. It will not die. When it is dividing, it is giving rise to two kinds of cells. One continues to be the cancer stem cell. শোনা যাচ্ছে? কোনটাতে যে চলছে হাজার হাজার contraptions. So this blue one is the cancer stem cell, right? When this is dividing, it is giving rise to two daughter cells. Now the daughters, this blue is the stem cell. So this gives rise to two daughter cells. One of them continues to be the cancer stem cell. Another cell forms the bulk of the tumor. Then again this is dividing. This one forms the bulk of the tumor. But some cancer stem cells are always there. This is how it evades death. Stem cells are always present in cancer. Angiogenesis, you know. Now, no matter like all these properties are there in a cancer cell. Even then, a cancer cell, a tumor cannot grow more than 2 millimeter in size without neovascularization, right? So the cancer does need new vessels, new nutrients to grow. A tumor cannot grow beyond 1 to 2 millimeter in size unless it has the capacity to induce angiogenesis. So angiogenesis is another driver mutation. Neovascularization is a process by which new vessels sprout from capillaries. The blood supply provides nutrients to the growing tumor cells. Now, what are the factors? Endothelial cells also secrete growth factors like IGF, PDGF, right? Insulin-like growth factor, platelet-derived growth factor. These growth factors also help the cancer cell to grow. The vessels are haphazard, not like normal vessels. Now, the vessels in angiogenesis of the tumor are haphazard. Normal, they don't follow the anatomy, right? These vessels proliferate more. They are haphazard. The endothelial cell junctions are not very tight. This helps the cell to metastasize. Angiogenesis forms the pathway for metastasis. বোঝা গেছে? So angiogenesis is an essential facet of malignancy. তারপরে angiogenesis আসবে short note, তারপরে angiogenesis is genesis of angio এসব লিখে চলে আসবে। কোয়েশ্চেনটাকে দুবার রিপিট করে চলে আসবে। আচ্ছা, invasion and metastasis. Invasion, you've already said, it is the local spread, and metastasis is the distant spread. Now metastasis, sounds, whatever it sounds, it's not very, it's quite difficult for the tumor cell. It has many steps. Now, the steps are not very important, but you just have to know this picture, you have to know. What happens, say this is the bulk of the tumor. This is the tumor, you can see, right? Now, these cells, this special green cells, they have the special metastatic potential. Now, what it has to do? It has to cut through the basement membrane first. There is the basement membrane of the tumor, of the organ. So, it has to cut through this basement membrane. How will it do it? MMPs, you have heard of MMPs, matrix metalloproteinase, collagenase, right? So, it will use these enzymes to digest the basement membrane material. Now, it has to travel through this extracellular matrix. There is the extracellular matrix between the basement membrane and the blood vessel. So, it has to travel through this extracellular matrix. First, it has to become loose. How does it become loose? Do you know which gene is involved? That is a twist and snail. No. E-cadherin. E-cadherin. So, it uses E-cadherin to become loose. Then it degrades the basement membrane, degrades the extracellular matrix, travels through the extracellular matrix, degrades the basement membrane of the blood vessel. The blood vessel also has a basement membrane. It travels through the blood vessel, then it has to pierce the endothelial junctions. Then it has to get into the bloodstream. Now the bloodstream, here it is facing other attackers, right? There are the lymphocytes, especially the cytotoxic T lymphocytes. One of the jobs of the cytotoxic T lymphocytes is to kill the cancer stem cell. Do you know that? What are the jobs of the cytotoxic T lymphocytes? Short note. CTL, FTL, tashe. One of the jobs of CTL, cytotoxic T lymphocytes, is to kill cancer cells. So, it has to get a potential where it can evade the attack by cytotoxic T lymphocytes. It has to then form a tumor embolus. Then again the whole process continues. The tumor embolus is formed with platelets. Then again the whole process continues and it has to again pierce through the endothelial junction, pierce through the basement membrane, get into the extracellular matrix or another organ, and then there is metastasis. So many steps in metastasis. Should I repeat? বোঝা গেছে? Now, evasion of immune surveillance. These two people got the Nobel Prize recently in 2018, I think. James P. Allison and Takushu Honjo. They got the Nobel Prize for discovering this evasion of immune surveillance. This I was talking about. Now, normal function of the immune, please stop talking. Normal function of the immune system is to constantly scan the body for emerging malignant cells and destroy them. This is the function of the cytotoxic T lymphocytes, right? MHC, etc. is all involved in this. I will not get into the details of this, but it's there. Now, this function is mainly performed by the cytotoxic T lymphocytes. The principal immune mechanism of tumor eradication is killing of tumor cells by CTL for specific tumor antigens. Right? Tumor antigens are presented on the surface by MHC class 1 molecules and are recognized by CD8 positive cytotoxic T lymphocytes. Now, Say this is the tumor cell. This is a receptor. This is recognized by the MHC class 1 molecule. Then this is presented to the CTL. This then kills the tumor cell. So, the tumor cell can be virus infected cell. For that, there are specific MHC molecules. Or they can be cells which have aberrant expression or excessive expression of some protein. Again, it is recognized by the MHC molecule. Or it can have a defective gene product which is recognized by the MHC molecule, presented to the, it's an APC, antigen presenting cell, and then it goes to the cytotoxic T lymphocyte which kills the tumor cell normally. So now the cell has to have a property where it can evade this kind of death, right? So how does it do it? Tumors may avoid immune system by selected outgrowth of antigen negative variants. Say there are, as I told you, there are driver mutations, passenger mutations, there are subclones in the tumor. Now one of the subclones, it is a tumor cell, but it does not have this. So it is not recognized by the MHC. Very intelligent actually. It is not recognized by the MHC. It is not killed by the CTL, right? Or loss or reduced expression of histocompatibility antigens, or immune suppression mediated by tumor cells. The CD8 cells can also be killed by some factors are secreted by the tumor cells. And then there is immune suppression, and that is how it can evade immunity, cancer-related immunity. Now this is, I told you this is important for PD1, PDL1. This is a newer therapy which has been discovered it is being tested for many cancers, but most importantly for lung cancer. Lung cancer is very important, happens a lot in US. All research happens in US. PD1, PDL1, these antigens are manufactured by companies in the US, bought by the whole world. And then we have to test for PD1, PDL1. All lung cancers have to be tested for PD1, PDL1, and then they are treated. This therapy is available also for bladder. So this is important right now as therapy for lung cancer, for bladder cancer. Genomic instability. Now, why do you think I have included this picture? I included this picture last year also. Why? And then it was asked in this semester, amar kache je kota khata esche, 2-3 people were able to answer. I included this picture so that you remember. Why do you think Angelina Jolie comes here? Why is she relevant? Yes, because she had inherited BRCA1, BRCA2 mutation, right? It is a inherited risk. So she had increased risk of developing breast cancer. Later on, she underwent another surgery. What did she remove? Which organ did she remove? Ovaries. Why? Same, BRCA1, BRCA2 mutation can also give rise to ovarian cancer. So she got rid of the problem only. Now she has no risk of developing breast cancer and no risk of developing ovarian cancer. Now, so that is why BRCA1, BRCA2, this is the question from breast cancer that was asked in the last semester. Now, patients with inherited mutations in genes involving DNA repair systems are at greatly increased risk of developing cancer. Now, we know that P53 arrests cell division to repair any DNA damage Mutation of p53 is a common finding in most cancers. It comes in every step of cancer, p53. Mismatch repair genes, I've already spoken about mismatch repair genes. Microsatellite instability causing HNPCC, other inherited DNA repair defects, nucleotide excision repair causing xeroderma pigmentosum. Do you know nucleotide excision repair causes xeroderma pigmentosum? Apart from that, it causes basal cell carcinoma, right? Bloom syndrome causes increased risk of leukemia. Ataxia telangiectasia, ATM gene is involved. It also has increased risk of leukemia, lymphoma. Fanconi's anemia has an increased risk of leukemia. Familial breast cancer caused by BRCA1, BRCA2. Also ovarian cancer, same, caused by BRCA1, BRCA2. Now these are the DNA repair defects. These genes are important for repairing the DNA. If there is any problem, a normal person can repair the DNA because problems occur all the time. But the normal person can repair the DNA because they have intact these genes. Nucleotide excision repair system or BRCA1, BRCA2 system or mismatch repair system, these are intact in a normal person. But a person who has an inherited risk in these inherited defect in these systems has an increased risk and needs to undergo surveillance. So these people will say a person who is 25 years old, we know has a defect in the mismatch repair system. So has an increased risk of HNPCC, has an increased risk of colon cancer. So from, I think the age is around 25, this person will undergo annual colonoscopy. And I think by the age of 35 or 40, will have to undergo colectomy, right? So that's what she did. She found out firstly that she has an inherited risk. Then possibly she underwent surveillance. And then when she decided that, okay, now I'm old enough, she underwent mastectomy or oophorectomy. That's it. Carcinogenesis is a multi-step process. A malignant tumor must acquire multiple hallmarks of cancer. Stepwise accumulation of multiple mutations act in complementary ways to produce a fully malignant tumor. Cancer-enabling inflammation, epigenetic changes also play a role. কিছু বোঝা গেছে এই ক্লাসে? It was a bit lengthy.